Hi, everybody. My name is Nicole Warren. Can you guys hear me okay? Looks good. Perfect. All right. So first of all, I think we are ready to get started. I want to thank everybody for joining us today, and I want to welcome you to the 14th Annual Research Symposium for the Center for Women's Health, Sex, and Gender Research. We are an interdisciplinary collaborative research group among the schools of medicine, nursing, and public health. My name is Nicole Warren, and I'm an associate professor at the School of Nursing. And I'm also co-chair of this year's event and very much looking forward to the afternoon. And I'll turn it over to Michelle.
Good afternoon, everyone. My name is Michelle Ogunwole. I am a General Internal Medicine Research Fellow in the Department of Medicine, Division of General Internal Medicine, and I'm equally as excited to welcome everyone to this event. I'd like to give you a quick overview of how today's going to go. So we're in the welcome right now, and we'll continue on with that, and then we will move we'll have a formal welcome, by one of the center's co-directors, and then we'll announce the recipients of this year's research grant and Women's Health Awards. And this will be followed by a number of flash talks by previous grant recipients. And next we'll have our much anticipated keynote address by Dr. Monica McLemore. And that will be followed by a panel representing a wide range of perspectives, from birth workers to researchers and public health leaders. And with that, I am going to hand it back over to Nicole for a few reminders.
All right, so during today's symposium, our conversations are going to range from sex differences in cytokine production to reproductive justice. So it's packed. And it's going to cover a diverse set of topics. So I want to encourage folks to use the question and answer function for questions that you have for either the keynote or the panelists as we go. We want to encourage you to tweet what you're hearing and hopefully learning, and tag us in those tweets at JH_Women's Health. You can also use the hashtags SABV, which is sex as a biologic variable, SDOH for social determinants of health, or you can just include the hashtag Hopkins Women's Health Symposium. And before we go any further, and I just want to say a couple of quick thank yous to Becca Urson, Patrick Shea, and Corey Farley for all their work that they have done and are still doing to make this symposium possible. So thanks very much to you all. So with that, I'm going to hand it off to Dr. Sabra Klein.
Oh, Nicole, Michelle, thank you. Thank you so much for, I think you two are the others who need to be acknowledged today, for really bringing to light this topic, bringing it to our center to begin these really important discussions. So thank you both for your leadership. Next slide. So I'm Sabra Klein. I am professor of molecular microbiology and immunology at the Johns Hopkins Bloomberg School of Public Health. And I am lucky enough to co-direct the Johns Hopkins Center for Women's Health, Sex and Gender Research with my friend and colleague, Wendy Bennett. Our center is an interdisciplinary collaborative research group made up of investigators at the schools of medicine, public health, and nursing here at the Johns Hopkins University. The mission of our center, which you will note we are in our 14th year here at Johns Hopkins, is to create a forum such as this one for discussion of research related to women's health, sex, and gender-based differences, to build and foster interdisciplinary collaborations that bridge clinical, epidemiological, and basic biomedical research relevant to women's health, sex, and gender research. We provide mentorship throughout the year and training opportunities for our students, fellows, and junior faculty who do research related to women's health, sex, and gender differences, some of whom you're going to hear from today. We promote career development from underrepresented groups in academic medicine and public health, including women, racial and ethnic minorities, and sex and gender minorities. We've also provided a centralized place for several of the signature fellowship and research programs of the NIH Office of Research on Women's Health, including the Johns Hopkins Building Interdisciplinary Careers in Women's Health Fellowship Program, as well as the Johns Hopkins Specialized Center of Research Excellence in Sex Differences Program. So I am honored to welcome you to today's event. We ask that if you tweet about today's event, please acknowledge and connect with our Twitter handle, which is located here. And so with that, I would like to welcome Wendy Bennett.
Great. Thanks, Sabra, for the welcome. And it's wonderful to work with you too. I can't believe we're in our 14th year. It is amazing. So I am thrilled that I am able to announce our awards. So we have 3 awardees first for our 2021 seed grants for research on sex and gender differences. So these are $50,000 pilot grants, and they are made possible by our strong collaboration. It's between the Johns Hopkins Specialized Center for Research Excellence, which is our SCORE that Sabra mentioned in sex and age differences in immunity to influenza, and our partnership with the Foundation for Gender-Specific Medicine. We are so grateful to Dr. Marianne Legato, who is here today and who you're going to hear from, for her generous foundation's contributions to these pilot grants. So each year we receive applications, and honestly, every year they get more and more amazing than the year before, and it's a very difficult decision. I really want to thank the reviewers listed here on this slide for spending time, contributing their expertise to review our awards this year. And now I'm pleased to announce our 2021 3 awardees. So the first awardee, drum roll, is Dr. Nisha Galotra, who is an assistant professor in cardiology, and her project is called Sex Differences in Myocardial Sequelae of COVID-19. Our next award goes to Monica Munier, who is an assistant professor in the School of Public Health in the Department of Molecular Microbiology and Immunology. And she is looking at sex differences in the immune response to Trypanosoma brucei infection. And the third award is going to Dr. Allison Gemmel, who is an assistant professor, again, in the Bloomberg School of Public Health in the Department of Population, Family, and Reproductive Health, examining the relationship between reproductive factors, metabolic syndrome, inflammation, and biological age acceleration in a population-based cohort. So congratulations to our 2021 awardees, who we are thrilled to support you, and we are thrilled to watch you grow and also hear about your work next year at our 2022 symposium. So on to our next award. So it's now my great pleasure to announce the 2021 Dr. Donna Vogel Women's Health Champion Award. So this award we created in 2016, and it was named after Dr. Donna Vogel, who is part of our symposium today, and I don't think has ever missed a symposium. And Dr. Vogel has been a champion of women's health and sex differences research. In her own words, when Dr. Vogel first entered the workforce, women's health as we knew it was not only a new discipline, but at the time it was very divisive. Some felt that the health and biology of women in areas other than OBGYN needed overdue attention, to the point that they wanted to exclude reproduction from the agenda. And some saw sex and gender differences research as really a separate priority, separate from women's health. So now we know that women's health and sex and gender research have grown to be an inclusive field. We think of them all together, and we work to build bridges and break down scientific and clinical barriers. And this award here at Johns Hopkins seeks to recognize investigators who have made women's health, sex and gender differences research a priority at the university, and who have demonstrated excellence in mentoring the next generation. So this year, I am especially pleased to award the Donna Vogel Women's Health Champion Award to our own leader and champion of women's health, sex and gender research, Dr. Sabra Klein, who, as you know, is a professor in molecular microbiology and immunology at the Johns Hopkins Bloomberg School of Public Health, also the co-director with me for our Women's Health, Sex and Gender Sex and Gender Researches Center, and she's the PI of the Johns Hopkins Specialized Center, the SCORE in sex and age differences in immunity to influenza. So Dr. Klein's nomination letter highlighted a lot of her accomplishments during this especially difficult year. And during this year, Dr. Klein has become a national as well as an international voice for the science around the importance of sex differences research on the immunology and effects of COVID-19. Her nominator wrote, Dr. Klein has been the recipient of 2 U54 Center grants that apply a sex and gender lens to COVID-19 serology and provide support to 7 distinct research projects focused on sex differences in immune responses using both human samples and animal models. These U54s also provide enhanced educational opportunities to incorporate sex differences and women's health into existing courses and seminar series offered throughout the university. Through our pilot grant program and core facilities, these U54s will improve and expand the analysis of sex, gender, and women's health in research projects throughout the university. These efforts will profoundly affect the consideration of sex, gender, and women's health in the research and education programs here at Johns Hopkins. So Sabra, from the bottom of my heart, I am grateful for your friendship, your partnership, your encouragement and willingness to brave all of our challenges as well as our successes in building our center together over these years. We have a beautiful engraved glass award that I will bring over to your office for you to display in recognition of this fabulous achievement. So congratulations. And now I'm going to move on to our flash talks. So we have a tradition at this symposium where we really want to highlight the work of our seed grant awardees, and we do it in a very quick way. So the idea of the flash talks is it gives them the opportunity to share a glimpse of their work with the idea that it's inspiring more conversation. It's supposed to create questions. So please put your questions in the Q&A. We might not be able to get to all of them today, but the idea is that these could promote future collaborations, emails, little cups of coffee in the future so that you can work with these fabulous seed grant awardees. I want to highlight Dr. Marianne Legato, who is here with us. Dr. Legato, are you on as one of our panelists? Can you, who would like to welcome, there you are, who would like to welcome our awardees. So Dr. Legato leads the Foundation for Gender-Specific Medicine, which, as I mentioned, has generously donated to support this pilot program. Since 2016, she has been donating to support our scholars. She's an internationally renowned pioneer and leader in the field. She's been a longtime supporter for all of our work in the center, and we're so grateful to now partner with her on this special program. So Dr. Legato, thank you, and feel free to welcome our seed grantees.
Thank you so much. Can you see me? Yes, okay. I just wanted to salute both Wendy and Sabra, whose collaboration I've enjoyed, as Wendy points out, since 2016. We're very proud of these seed grants, and we are very happy to make an annual contribution to you and to help you further support for this immensely important program, which I think is on the verge of real expansion. So congratulations. It's delightful to hear about your next 3 awardees, and I'm very proud that we have been able to contribute anything to your program.
Wonderful. Thank you. Thank you very, very much. So we're now going to start our flash talks. And the way this works is each presenter will then introduce the next presenter that comes after. So I'm going to first introduce Dr. Balsamo Anagastu of the Sidney Kimmel Cancer Center. And welcome, and we look forward to your talks. Thank you.
Thank you, Wendy, and it's a great pleasure to be here and present our work. I'm Elsa Anagastu, an assistant professor of oncology here in the Cancer Center, and today we'll present our work on sex-specific genomic determinants of response to immune checkpoint blockade. This work was supported by the SADI-SCORE seed grant. Next slide. Immune checkpoint blockade has changed the landscape of care in many malignancies, and that includes lung cancer, where treatment with immune checkpoint blockade increases overall survival, both as monotherapy and in combination with chemotherapy. And recent meta-analysis across multiple tumor types have shown that male patients may actually derive more benefit from immune checkpoint blockade when compared to female patients. And as shown here, men that are shown in blue benefit more than women that are shown in red, in melanoma, in lung cancer, and other tumor types. And this is independent of the class of immune checkpoint inhibitor and line of therapy. And the mechanisms that underlie this sex dimorphism in immunotherapy response are unknown and are likely to be multifactorial. The sex-related differences in prevalence of exposures in smoking, more specifically, as well as oncogen-driven lung adenocarcinoma, these only partially explain the differential responses. Females have well-established differences in immune responses as compared to males, including increased humoral and cell-mediated responses in autoimmunity. A demonstrates stronger tumor immunoediting in the tumor microenvironment, which may in turn be reflected in differences in therapeutic responses in the context of immune checkpoint blockade. Next slide. We therefore, what we did is we investigated sex-driven differences in tumor and host genomic features in two cohorts of non-small cell lung cancer patients treated with immune checkpoint blockade. Whole exome sequence data was analyzed to derive tumor mutation burden and immunogenic mutations in neoantigens for each case, as well as HLA class 1 and class 2 genotypes. HLA-1 and 2 germline diversity was combined with genome-wide copy number analysis and loss of heterozygosity events to determine somatic HLA class 1 and 2 genotypes in the cancer cells. And what we found is very briefly summarized here, which is that females with durable responses, and durable responses here are shown in blue, or durable clinical benefit, DCB, women with durable responses had higher tumor mutation burden than females with non-durable clinical benefit, which is now shown in orange. Similarly, female responders harbored a significantly higher immunogenic mutation load predicted for both HLA class 1 and class 2, and these are shown on the middle and right-hand side. This was not appreciated in males. Next slide. Then we looked at HLA diversity as an indicator of neoantigen presentation capacity in each tumor. There were no associations between germline HLA class 1 or 2 zygosity or outcome. However, when we combined immunogenic mutation load and class 1 and 2 zygosity, we found that increased HLA diversity in tumors with a high immunogenic mutation load was associated with clinical benefit in males now, but not females. Next slide. Therefore, we conclude that through our analysis of whole exome sequence data, we identified a unique sex-dependent genomic and neoantigen footprint of response to immune checkpoint blockade, such that clinical benefit was associated with higher tumor mutation burden, class 1 and class 2 immunogenic mutation load in females. And interestingly, in males, clinical benefit was associated with higher class 1 and 2 immunogenic mutation load only when combined with maximal antigen presentation capacity. And we're now working on functional studies to characterize differential neoantigen-specific responses in men and women with lung cancer treated with immune checkpoint blockade. So Thank you for your attention, and I would like to turn it over to our next speaker, Sam Das.
Thank you, Balsamo. And I'm Sam Das, and I'm assistant professor in anesthesiology. I also would like to thank the organizer for giving us this opportunity to talk about the microRNAs in female hearts. Next slide, please. So if we consider this yellow circle as all the microRNAs so far we identified from 1992 to today, it will be more than 5,000. However, if we consider the black dot at the right-hand side of the corner, today my focus will be to explain that powerful nature of that microRNA. Can you click? That's an animation. Yeah. So what we will try to say, these three microRNAs are only microRNA has been identified that can come to mitochondria or that can translocate into the mitochondria. So we term this as a mitomine. Next slide, please. So it's a very busy slide. I don't want anybody to bore you with all the details, but if we focus on the left-hand side, that's the nucleus. That's where this microRNA 181C get transcribed, matured in the cytoplasm, and then translocate into the mitochondria, where it kind of bind to a mitochondrial gene and regulate that gene function and make excess ROS. And then there are complicated integrated signals, which makes a mitochondria to nuclear signaling, goes back and forth. And finally, in the mitochondria, we see accumulation of calcium. And that is a hallmark of heart failure, ROS, excessive oxidative stress, and overload of mitochondrial calcium. So we identify the small microRNA 181C can induce both two factors. Next slide, please. So from our previous studies, we identified that mitochondrial function regulated by ROS production in female heart, premenopausal female heart, is less than the male, same aged male heart. So we wanted to know whether microRNA 181C has any role in this paradigm. Next slide, please. So with the help of this seed award, we identifies indeed in female premenopausal mouse heart has almost threefold lower microRNA 181C expression. Next slide, please. And we identified in a long molecular signaling studies that female heart, because of its less microRNA 181C, it produced less ROS and calcium. But all of these mice were between 4 to 6 weeks, so premenopausal. Next slide, please. So we wanted to try overectomized mice, whether estrogen has any role in this. Unfortunately, that was our aim too in the seed grant, but doing this assay, we identified no, there is no relationship between estrogen and microRNA 181C expression. However, what we identified, it's very interesting, if we age these mice up to 12 weeks, the microRNA 181C expression completely flipped. Basically, if you look at the male, which is in the white bar, and the female black bar, if you look at this condition, when 12 months of age, now female mice express more microRNA 181C compared to the aged matched male. And all of these mice were C57 black 6. Next slide, please. So that's my thank you for my team, my collaborators, and we are trying to identify how we can relate this female age-associated microRNA 181C expression and which relates to the heart failure. Thank you again. And now I would like to introduce Joanna, and she's going to talk about sex-specific effect on gender variation. Thank you.
Thank you very much. As he said, my name is Joanna Amelia. I'm an assistant professor of medicine in the Division of Gastroenterology and Hepatology. And it's my pleasure today to present our talk titled Sex-Specific Effects of Genetic Variation in the Manganese Transporter ZIP8 and its Effect on Intestinal Inflammation. I want to acknowledge up front my postdoc, Dr. Lakshmi Shunawar, who has helped a lot with this work. Next slide, please. ZIP8 is a manganese transporter that is needed for manganese homeostasis, and specifically it seems to act at the bile canalicular membranes in the liver to help reclaim manganese from bile. As you just started to hear about in terms of redox homeostasis, particularly with ROS production in the mitochondria as an example, manganese is a critical cofactor for a number of enzymes. It participates in redox homeostasis, and it is very important in protein glycosylation. It is well known in humans that manganese homeostasis is sex-specific. As an example, females require less manganese in the diet, but tend to have higher blood manganese levels than males. The reasons for all of those differences are not fully understood yet. Approximately 7% of the global population carry a missense polymorphism in ZIP8, and that polymorphism is the polymorphism we specifically study. It results in hypomorphic function of ZIP8, and it results in a relative manganese insufficiency in humans. What's interesting about this polymorphism is that it actually ranks in the top 10 of polymorphisms associated with human disease. Some of those diseases are illustrated there to the right. We're most specifically interested in its association with an increased risk of Crohn's disease, but it is also associated with neuropsychiatric phenotypes, such as an increased risk of schizophrenia, and cardiometabolic phenotypes as an increased risk of BMI, of elevated BMI. Overall, we think that these genetic associations really suggest an underappreciated contribution of manganese homeostasis in human disease. Next slide. So our central hypothesis that we're testing in this seed grant is that under inflammatory stress, there is a ZIP8 genotype dependent and sex-specific perturbation of manganese homeostasis. Next slide. We have developed a novel mouse model using CRISPR to knock in the human variant into the mouse ZIP8 gene, which is approximately 85% homologous to the human ZIP8. Doing that, we've done a couple of studies. I want to just highlight two of them. One, with our specific interest in Crohn's disease, we've tested the mice using a chemical model of colitis and found some interesting sex differences there. So here are some histologic pictures of the distal colon in mice that have been treated with the chemical-induced colitis model. And what we noticed off the bat was that the male knock-in mice are more susceptible to DSS-induced colitis. You can see somewhat in those boxes that are squared there, there's increased inflammatory infiltrate in the mucosa and increased edema. And if you go to the next slide. The opposite, however, was true in the female mice. Our knock-in mice actually exhibited relative protection in the DSS model. And indeed, we've gone on to test whether this is dependent on manganese in the diet and have found that these differences are even more stark when manganese is reduced in the diet. Next slide. And the other interesting point I want to emphasize is a new finding that we have in terms of manganese homeostasis in the setting of inflammation. We've established that our mice, because ZIP8 is functioning to transport manganese from the bile, in our knock-in mice, they have elevated biliary manganese. And this is true in both males and females. And there is a trend towards increased biliary manganese in the females compared to males. Upon inflammation, if you go to the next slide, we see marked increase in biliary manganese. That's true in both males and females. And it really underscores a potentially a new change in manganese metabolism that may be very critical to understand. Next slide. So in conclusion, we've established that inflammation increases biliary manganese excretion in mice, and we are going on to understand whether this changes manganese-dependent mechanisms specifically in the liver. We've established that male ZIP8 knock-in mice are more susceptible to injury in a chemical model of colitis than our female knock-in mice. And that work is ongoing to try to understand what might be underscoring that difference. Reduced dietary manganese accentuated the sex-specific phenotypes in the chemical model of colitis. And finally, these findings drove us back to human data to try to understand if the association between this genetic variant and Crohn's disease, if that shows sex specificity. And we actually did find that the association is more specific in males. However, it is still significant in females, underscoring that there's much more to understand here. I want to thank you very much for this funding and help with this project. It's my pleasure to introduce my colleague, Dr. Christina Montemere, who will present our next talk.
Thank you, Dr. Amelia. I'm an assistant professor of medicine in pulmonary and critical care division, and excited to talk to you for the next couple of minutes about some recent work entitled Female Sex is Associated with Increased Pulmonary Exacerbations in People with Cystic Fibrosis. And we can go ahead and move to the next slide. And as a background, pulmonary exacerbations are a major contributor to disease progression in people with CF. And those that may not know what a pulmonary exacerbation is in the CF population specifically, it is an increase in respiratory symptoms and or decrease in lung function requiring antibiotic treatment. And for the purpose of this study and the majority of clinical trials, it's antibiotic treatment through the intravenous route, so IV antibiotics. Some of our colleagues in the field have shown that CF has been shown to have an increase, females with CF have been shown to have an increased rate of pulmonary exacerbations per year compared to males, so 2.2 exacerbations per year versus 1.7. This was data though from 2006 to 2014 and has not been looked at extensively since then. So overall research identifying sex differences in pulmonary exacerbations among some populations and people with CF is limited. So we sought to evaluate whether the annual rate of pulmonary exacerbations differed between females and males with CF across demographic and disease characteristic subgroups. And in order, just want to acknowledge up front to Dr. Natalie West, who is my primary mentor with this project, as well as Kevin Soder, who's our biostatistician. And the three of us worked pretty extensively on this. So we'll move to the next slide. And as you can see here, I tried to just put one graph of our overall results. And what we did is we used data from the CF Foundation Patient Registry, which includes approximately 90,000 people with CF nationally. And for this study, a total of 40,782 individuals met inclusion criteria. And overall, females comprised 48% of the study population. And what I'm showing you here is a comparison of the annual rates of pulmonary exacerbations for females with CF compared to males for CF from 2006 to 2019. And overall, you can see that in the cohort, there is a 29% higher relative rate of annual pulmonary exacerbation for females as compared to males. And looking through age group, race, ethnicity, Delta 5 FO8, which is the most common mutation in individuals with CF, as well as overall mutation categories. While there was no difference between sexes in the annual rates for children 0 to 5 years, adults 52 years or older, or those in mutation categories 4 and 5, higher rates of pulmonary exacerbations were observed in the majority of other age, race, ethnicity, Delta 5 FO8 mutation, and overall mutation categories. We can move to the next slide, please. So overall, we show this analysis has not yet been done in the CF population yet. So we're showing kind of for the first time that the annual rate of pulmonary exacerbation was significantly higher in females overall and across demographic and disease subgroups. The increased rate of pulmonary exacerbations begins in early childhood, likely contributing to the worse morbidity and mortality that we are seeing in females with CF. And as a future direction, I'd like to have a further understanding of how endogenous sex hormones impact respiratory health in females with CF, as that remains a critical knowledge gap that we hope to address. Thank you for your time today. And I'd like to go ahead and present our next presenter, Fenna.
You're muted, Fenna.
Thank you. Thank you all for having me present my work today and the pilot project on sex differences and the COVID-19 cytokine storm. Yeah, thank you. So despite similar SARS-CoV-2 virus infection rates, there's one slide missing. My first slide is missing. That's strange. Okay, well, I can.
Just a moment, and I'll see if I can pull it up.
It's okay. I have it open also on my end, but in case. It's the introduction slide. It's not about my data, so it's okay. I can talk about it.
All right, go ahead.
Yeah. So despite similar SARS-CoV-2 virus infection rates, men are more likely to suffer from severe complications and die from COVID-19 than women. And one of the underlying mechanisms of this sex difference may be the severity of the cytokine storm, which is an exacerbated inflammatory cytokine response that can severely damage the body and contribute to the COVID-19 mortality. And by using human bronchoepithelial cells, we are testing the hypothesis that SARS-CoV-2 related cytokine storm generated in part by these cells is greater in males than by cells from females. And this work has been done together with a talented postdoctoral fellow in my lab, Dr. Sylvia Sanchez. And now you could show my results slide. Thank you. So we're currently assessing the cytokine differences in male-female pairs from different race. And in our preliminary data from Hispanic males versus females, we found that the overall female bronchoepithelial cells produce significantly lower cytokine levels than males 72 hours post-infection. And that's what you could see, the males in the green and blue, and then the females in pink and orange. When we focused on those cytokines that were most expressed, we found that treatment with 0.1 millimolar budesonide, which is a beta adrenoreceptor agonist, reduced the pro-inflammatory cytokine production, but not anti-inflammatory cytokine and chemokines. So it's really that the pro-inflammatory cytokines from the cytokine storm that are being suppressed by this budesonide. And oddly, we see a similar effect with 0.1 millimolar imiquimod, which is normally an immune activator by acting as a toll-like receptor 7 agonist with known antiviral activity. So the fact, and in addition to these drugs that we used to suppress the cytokine storm, we also looked at viral titer. And as you can see on the right side of the slide, we looked at viral titers 48 hours post-infection, so a little earlier than the cytokines. And we found that, lo and behold, budesonide especially was able to reduce the viral titer besides affecting the cytokine storm. And that was something that was kind of unexpected. But it also agreed with a randomized control trial that was recently published, where patients were given budesonides to control the COVID-19 infection. So next slide. So our next steps are to further investigate the sex differences in the cytokine expression upon SARS-CoV-2 infection, as well as investigating the role of X-linked immune-related genes versus sex steroid hormone responsive genes in this SARS-CoV-2 related cytokine storm. And long-term, we hope to use this model system to test the effectiveness of these immunosuppressive therapies that could mitigate the cytokine storm and even maybe accidentally be antiviral as well. So it's important to understand the factors that contribute to the sex-specific severity of the SARS-CoV-2 related cytokine storm. And that way we could find treatments and vaccines that can be developed and that are equally effective for both men and women, especially when one is more susceptible than another. So my last slide, science is teamwork, and I would like to acknowledge the Hopkins School Foundation and for Gender-Specific Medicine for supporting my research and all the people that have been collaborating. And with that, I would like to introduce Dr. Shannon Wood, who will talk about the COVID-19 impact on IPV for pregnant women in Ethiopia.
Thank you, Fenna. Thank you all so much for having me today. I'm so thankful to represent the gender team here at CDSCORE. Next slide, please. So I'm speaking about intimate partner during pregnancy. And we know from media attention and past evidence from pandemics that pandemics increase gender inequities, specifically intimate partner violence and access to support services. Intimate partner violence during pregnancy is particularly critical given increased risk of miscarriage, premature labor, low birth weight, and maternal depression, but it's also a very critical point for intervention, given access to antenatal care and postnatal care. We focus our study on Ethiopia, where 27% of ever married women aged 15 to 49 have experienced IPV in the past year, and 4% have experienced IPV during pregnancy. More specifically, help seeking is very low. Of those experiencing IPV, 66% never disclosed nor sought help for the violence that they were experiencing. So this study is nested within PMA Ethiopia, which is a cohort study of recently pregnant women. And we sought to first examine if and how the COVID-19 pandemic impacted recently pregnant women's experiences with IPV, and then also to explore recently pregnant women's met and unmet needs for IPV referrals and resources and how these evolved due to COVID-19. Next slide. So we first did this with a secondary analysis of quantitative data. And the cohort was perfectly divided actually between pre-COVID and during COVID-19. So we were able to compare this pre-COVID and during COVID-19 time periods. And so we see that overall violence during pregnancy increased with an adjusted odds ratio of 1.3 from 10.5 to 15.1 over this period. And then we also stratified this by urban and rural, as we're suspecting that this might increase more prominently for urban women, given restrictions on movement in those areas. And it's exactly what we saw with an adjusted odds ratio here, concentrated of around 2.9 for urban women specifically. And we did see some non-significant trends for rural women as well. Of note though, rural women experienced IPV at both pre-COVID and during COVID levels that were higher at both time points than urban women. Next slide. Then we sought to understand women's needs and unmet needs and what that the impact was on IPV help seeking. And so this grant specifically funded a qualitative phase with 30 women. And so I want to pull out some of these quotes because I think that they're really helpful. So the first one, before COVID, we were having coffee together within the community. We were discussing with friends, families, and neighbors, but after COVID, things were changed. I worried how to discuss with families and friends if something happened to me because no one went to others' homes during this time. We were staying most of the time in our home. Even when you face violence during this time, it was forbidden to look for advice from friends or neighbors. During this time, I didn't look for any help or support as a result of violence. And for another woman, nothing has changed. I was silent then and I'm silent now. I can't talk about it. And so even though we did see increases in violence, specifically in urban areas, it really depended on residents, husband's occupation, economic impact, and time spent at home. Overall, women didn't feel like they had a difference in access to services and that had been impacted. In rural areas specifically, they didn't feel like that had been impacted because many of them didn't use these services pre-COVID, but they did feel like their access to their informal networks, to the people that they previously talked to, that was really what had been impacted. So they didn't feel like they had that disclosure piece that they previously felt supported by. So our next steps, we are currently preparing 2 manuscripts, and I would just like to thank my collaborators, Rebel Yurgu, who has really been leading this work in Ethiopia, as well as Dr. Linnea Zimmerman, Dr. Michelle Decker, and Dr. Nancy Glass. Thank you so much.
Wonderful. Thank you so much to all of our SEED grant awardees. Amazing presentations. It's great to see your work progress. We have a few minutes for questions. And so I know there were a few in the Q&A, and it looks like there was one for Shannon. Maybe Sabra, do you want to start with your question? I'm happy to read it off, or you're welcome to.
Oh, thank you, Wendy. Yeah, Shannon, I thought that was rather interesting, the comparison you made between rural and urban locations. And I guess I was wondering, is there an interaction with education level that could impact the greater IPV among rural than urban women?
Yes, that is a great question. So we actually, they were highly correlated between education and urban rural was. So we actually ended up excluding that from our adjusted models, I believe. But we did try to dig into that, and there was quite a bit of collinearity.
So does that give any hints about public health interventions, you know, that are there, yes, promoting education as a way to reduce some of these types of disparities?
Yeah, that's a great question. I think certainly in rural areas, if we were to take out the COVID piece, right, we see that the IPV is much higher in rural areas. And also we have other results specifically digging into sexual violence. And we see that sexual violence specifically in rural areas is incredibly high. And so I think that there we would definitely want to dig into education much further. But overall, when we're looking at specifically the COVID impact, you know, we really didn't see too much there because we were more focused on the restrictions on movement and social distancing and all of those pieces that we were seeing much more in urban areas than rural. That's a great question, though.
Great. I think some of the other questions were answered as we went along. And let me just see from our audience, are there other questions that people have for our SADE grant awardees? You're welcome to raise your hand and we can call on you, or you can put them in the Q&A before we move on. Okay. All right, well, thanks to everyone for your presentations. We really enjoyed them. Oh, it looks like there is one. Nicole, do you want to say your question?
Yeah, I was just curious, and I might apologize if I had missed it. How early did the changes that you saw in sex in cystic fibrosis? I'm sorry, I'm missing the scholar's name. I just was curious how early those were detected in life. Did you mention that? I apologize.
Hey, Nicole, it's Christina. Yes. So in this study, there were no difference in the individuals 0 to 5, but in individuals starting at in the 6 to 11 cohort, we started seeing that females had more exacerbations than males.
Okay, thank you so much.
You're welcome.
All right, great. And speaking of Nicole, I'm going to pass it off to you to introduce our keynote speaker. Thanks, everybody.
Yeah, thank you. We are incredibly efficient today on Zoom. I'm excited. We are running just about 9 minutes early. And the only reason I mention that is because I know there are a few folks who are probably joining with a particular interest in our next speaker. So without further ado, I'm just going to do a quick introduction and just say that this is a huge pleasure. All of you probably know that last year our symposium was canceled because of COVID. So we had gotten Dr. McLemore lined up and ready to go and had to cancel. And just personally and professionally, that was such a bummer for many of us who were excited to have her on our campus. So I'm very grateful for her, her willingness to come back a second year in a row working with us. And this is the first time we got to pull it off. So I want to remind everybody quickly before I do the introduction that Dr. McLemore, after her keynote, will have about 10 minutes of Q&A just really for her talk. And then, of course, in the panel later, but I just wanted to remind folks to use the Q&A for any questions that come up. So let me start by saying that Dr. McLemore is a tenured associate professor in the Family Healthcare Nursing Department at the University of California in San Francisco. She's an affiliated scientist with Advancing New Standards in Reproductive Health and a member of the Bixby Center for Global Reproductive Health, which I know many folks on the Hopkins campus work with. She's currently the chair-elect for Sexual and Reproductive Health section of the APHA and a fellow of the American Academy of Nursing. She's retired from clinical practice as a public health and staff nurse after 28 years of experience. And her program of research now is really focused on understanding reproductive health and justice. Her impact is reflected in 67, and I'm sure by now it's actually more than that, peer-reviewed articles that range from original research to op-eds. I mean, you name it, and she has put it out there. Her work has been cited in 3 amicus briefs to the US Supreme Court. Her data visualization project entitled How to Fix Maternal Mortality, the First Step is to Stop Blaming Women, was published in the 2019 Future of Medicine edition of Scientific American. Her work is really, it's everywhere. It's on HBO, it's on NPR, which is where I first that's where I first was introduced to her. But wherever you access Dr. McLemore's work, she is clear. She demands action, she demands accountability and awareness. And I don't think there's a question that she is one of the most influential voices in nursing in our country today. I think that's also true for reproductive justice and just health equity writ large. So I'm personally grateful for how she has shaped my teaching and my own practice, and just very honored to have her here today. So Dr. McLemore, thank you for coming. And it's my understanding that you would like to drive. So I'm gonna let you, I think Becca's gonna relinquish the screen and let you take over.
Well, thank you, Nicole. I am so grateful to be here. For people who know me, you know I have personal and professional links to Hopkins via my sister is a tenured professor of biology at Morgan State, and for years she did work with Estelle Gouda in pediatrics at Hopkins and did a lot of summer research projects and was really able to support the students. I think people may know that Dr. Carolyn Suffren is a good friend, colleague, and collaborator, and I just am very, very grateful to have an opportunity to be here with you all. First of all, I hope everyone had a great Mother's Day on Sunday. Someone noted in the chat that the Office of Women's Health is having a symposium today because for people who don't know, it's Women's Health Week. Like, it's super cool. And for people who don't know, tomorrow, May 12th is always the birthday, of course, of Florence Nightingale. And so we are in the midst of National Nurses Week. So a lot of really fun, interesting stuff going on this week. And I'm very grateful to be here with you all. A couple of things before I start. Thank you for such a kind introduction. And you're absolutely right. My publications are now at 71. More to come, including new amicus briefs to the Supreme Court. And I want to talk a little bit about my lapse in clinical retirement. One of the things that I thought was really important to do was to help with the COVID-19 vaccine response. So I have been vaccinating people with some volunteer projects in the Black communities here in Oakland, at schools and churches. And I think that that's very important as we start to turn the needle and move beyond at least the most acute parts of this pandemic. I do want to remind everyone, however, that, it is still raging in parts of the world, and we really will need to reflect on the trauma and the harm that we've all collectively experienced over the last year and a half. So I don't use the language that we are emerging from or going back to normal specific to COVID-19. Anyway, I've set up a couple of slides. I think I have about, 29. I've tried to leave a lot of time for discussion, for comments. You have my affirmative consent to screenshot my slides. You have my affirmative consent to post on social media. You have my affirmative consent to use any statement that you feel that I say might be helpful, because amplification of thinking about how we can do our work differently is super important, and it matters in a lot of different ways. Please use the chat. You can use whatever way that you need in order to communicate with me and with the participants in this symposium is totally fine with me. That said, I use she and her pronouns, and I think it's super important that you understand that I'm trying to start and change and curate different kinds of conversations. And my underlying thesis is this: we are all using the same words, but we're not all having the same conversation. And that's one of the reasons why I started to really think deeply about Retrofit, Reform, and Reimagine, to give people a language as well as a shared appreciation for how this operates and the important work that we're trying to do in health services provision, in public health, and in policy. So I'm going to take you on a journey. I always think that the gold standard that we use to interview patients around receiving patient history as a gold standard is something that we should replicate, particularly in our own positionality and how we do our work and how we do our research. I personally, the most important bullet on this slide is that I was born a preemie in 1969. So all the work that I do is really personal. It comes from a very personal place. For people who know my background, I loved hearing from the early career investigators and the people around funded work. I mean, we heard about immune checkpoint blockade. We heard about microRNAs. We heard about manganese transporters and ZIP8. We've heard about cystic fibrosis, and we heard about sex differences in cytokine storm, all the way to intimate partner violence in other countries. I mean, as a laboratory trained original scientist, public health nurse, and trained clinical person, I'm grateful that I got to hear from all of those grantees. So congratulations, because as we share our work, it's really important that we amplify the important findings of our scholars and our colleagues. But I was really enough at Black woman, regardless of all the accolades that have been listed. And one of the things that I think is super important is that Black women have a unique positionality for us to think about our science, our scholarship, our policies, and the work that we do. I also want to point out there's been a very interesting use of sex and gender and women's health. And so that's been really super fascinating for me to observe, because I view all of those things as unique, distinct, but also interconnected. So for clarity, I think it's very important that we appreciate that when at least in the world that I sit in, pregnancy is the condition or capacity for pregnancy is really the sort of situation and circumstance that I study. Right? A lot of people study birth, they study abortion, they study infertility, they study surrogacy, they study, reproductive cancers. Like, in my mind, pregnancy is really the condition. All of those other pieces are outcomes. And I think about it from a reproductive justice perspective, that those outcomes are all legitimate. And so when we start to use reproductive justice, and when we start to think about retrofit, reform, and reimagine, it allows you to have different conversations with people. I also like to remind folks, since I work with pregnant capable people, or people who have the reproductive organs that generally afford them the capacity to become pregnant, that most people will spend the bulk of their reproductive lives avoiding pregnancy. So we just saw that sort of very interesting study in the New York Times that was being reported on around the birth rate declines in the United States. Some people are attributing this to the COVID-19 pandemic. I would argue that our birth rates have been dropping for decades, and that it's really weird that we tie our sort of financial policy and a whole lot of other kinds of policies to birth rates. I think that's really weird, and we need to interrogate that at some point, particularly in the context of understanding and appreciating that most pregnant capable people will spend the bulk of their reproductive lives avoiding pregnancy, because most people only have between 2 and 4 children, right? So if you actually have between 25 and 30 years of fertility, you're actually going to spend more time avoiding pregnancy than actually being pregnant. The other piece of work that I'm very grateful for is understanding life course theory. So looking at the fact or the notion that every time point in one's life is an opportunity to impact the outcomes and the influencers of health is super important. I'm going to get on the social determinants of health as I move forward in the talk, because I have a whole orientation that I would like to invite you into a different conversation about how to think about those. So let's start with some pictures. I'm a big fan, I'm a visual learner, and I'm a big fan of using photos and words together to help people understand concept. So if you don't know Katie Casamano, she is an incredible health services researcher at the University of Minnesota, and she's been doing some really, really great work looking at Medicaid populations, not specifically, but they've been a huge focus of her work. And she's also talked quite a bit about the rurality of health inequity. So people who live in rural environments. And one of the most poignant things that she's talked about is the downstream or intergenerational impacts of hospital obstetric unit closures. And when I saw this quote from her, my mind, like a light bulb went off in my head. And I sat there and I said to myself, you know, we have built so much infrastructure around pregnant, capable people, especially in nursing, where, you know, they can, for most part, they can bypass emergency departments because we build OB triage, right? So that we could get people to the timely care that they would need around childbirth. And I couldn't, it begged me to ask this question: what happens to all that expertise when we close obstetric units? Like, do those nurses, what happens to them? And so Dr. Lisa Wolf, who actually is the director of research for the Emergency Nurses Association, she had the same question. And so we got together and recorded a webinar to really think about pregnant, capable people and what skills they would need if emergency departments had to pick up the triage of those patients and those individuals. And so what we found is that that expertise is lost in a lot of places when those obstetric units close. And so I bet you never thought that we would have to really tie the knots together between this notion of obstetric unit closures, as well as, you know, this whole idea that labor and delivery knowledge was being lost, right? So that's piece one. Piece two, we have a lot of pregnancy help centers. We have crisis pregnancy centers. We have all sorts of social entities that have cropped up to try and help pregnant people. And yet many of them are not licensed clinical facilities. So this came up to a head in 2019 when we really saw that Title 10, or the program that funds family planning services that was signed into law by President Nixon in 1970, they're just now celebrating their 50th anniversary, was really being reduced and under attack. And so what we saw was patients were being confused about where they could seek either contraception services or referrals for abortion or infertility, because there was no synergy, there was no coordination, and there was no sort of minimum basic standards around the sort of social services that were providing supports to pregnant, capable people, and the clinical supports that were providing services to folks. So we get this confusion because from the public's perspective, it doesn't look relatively different. Again, we're not all having the same conversation. I published this work with the Birthplace Lab, which is in Ottawa, Canada, under the direction of Dr. Saraswati Veedam. And what we figured out was that, you know, 1 in 6 people, regardless of race or ethnicity, stated they experienced mistreatment during childbirth. And some of the most common ones are things that really stunned us. You know, healthcare providers refusing to help people, not being responded to in a reasonable amount of time, being scolded by healthcare providers, violation of physical privacy. When we looked at these data, we weren't looking to blame patients. We weren't looking to blame providers and healthcare systems, because we knew, like a light went off in our head that said, wow, our workplaces are inhumane. No wonder clinicians are burnt out, and no wonder patients are being mistreated. It's because the environment in which we're trying to provide care is inhumane. It's not working for any of us. It's not working for the patients. It's not working for the providers, right? That opens up a really different conversation of what the solutions are, as opposed to pitting people against each other around blame. I was pretty stunned when Serena Williams wrote about her birth story in the January 2019 edition of Vogue. I've been a Vogue subscriber since I was 17 years old. And one of the things that was so fascinating to me was the fact that she was a near miss. And so as I read her account, and as I've heard her talk about her story, and many, many others, because we estimate that there's like 50,000 near misses using the data from ProPublica and NPR, the Lost Mothers series, where we almost lost people who died. Like there's all this attention around maternal morbidity and mortality, but the near misses, right? The people who like survive a traumatic pregnancy, we don't nearly talk enough about that. Again, a different conversation. And what I always say to people is, if you're less inclined to believe someone, then we already are at a disadvantage in terms of symptom recognition or signs and symptoms of deterioration, right? If we're not believing you, we will miss all those different things that would set off our spidey senses tingling to get us to think about, oh, maybe this might be going on with this person. So that's problem one. Problem two is even worse, which is a team problem. So if we have team members in conflict with each other, if the doulas manage the anesthesiologist manages the obstetrician, nobody's got their eye on the patient, right? So this is why simulation can become a really interesting tool if you have a different conversation about the responsibility that it's all our jobs to make sure that we don't have near misses, let alone deaths. Then you can have a different discussion instead of pointing fingers at each other. So you can imagine 9 months later in the September vote, when Beyonce told her pregnancy story and talked about toxemia of pregnancy, I was pretty stunned to see how many legacy institutions, including my own, had myths and flat out old science on our legacy websites because we have not figured out or thought about science communication to the public differently. So the first thing I did was I went to our own university website after she talked about toxemia pregnancy, and we realized, for people who don't know, preeclampsia, right? I mean, our own personal UCSF website still didn't have the information that preeclampsia could exist in the postpartum period, right? Even though our social media had updated information, and even though you could access that information on clinic-specific websites, the overall website was not coordinated with that messaging. And how many times have we seen this again, where we have tools that we're trying to use to communicate to the public are discordant in terms of the information that's housed on them, right? So there's a whole another conversation we need to have around, maybe we'll just put basic information on legacy websites, and that we'll update the public using other tools that are more rapidly and more easily corrected. They discussed, Nicole discussed in my introduction around this scientific data visualization piece. And for people who don't know how big of a deal this was, number one, Scientific American has been the most continuously published science communication tool in the United States for like 35 years, I believe it was, might have been 185 years. The Future of Medicine edition has always come out in May. I did try to get them to change the name, but it's been that, because I wanted the future of healthcare, but they were like, no, it's been that since the beginning, since we started publishing. And they originally wanted me to talk about the root causes of maternal death in the United States. I said, no, I can't write something like that. Because if I'm going to contribute to a narrative, I want to give people solutions. I want to seed ideas about how we can collectively start to think about fixing this. I was stunned that the entire issue was all about sex and gender, women's health, the entire issue, all the invited pieces. And that was a first, right? In 2019, that was a first. So we need to keep thinking about where we place our work. I fought for this, and I'm so glad it was able to be part of that data visualization piece, which you can see for free if you go through the Black Mamas Matter Alliance website and you click on literature, you click on resources. My piece is the first one there. No paywall, no firewall, nothing. Because I wanted to model the notion that you have to go through Black women to see and review and utilize our scholarship, right? Once a data visualization with Scientific American is over, it becomes yours. You don't sign over a copyright. And so I wanted people to have to go through Black women to see it. This was an important panel in that frame because I wanted people to know that there were things that we could do to prevent that 60% of cases of maternal morbidity and mortality, regardless of what your race and ethnicity are considered preventable. And I wanted people to know that. That helps you to curate a different kind of conversation about what those potential solutions can be. So I had an initial reaction, and I've always had an initial reaction to social determinants of health framing and language, because I don't think we talk about those in the same way. So this is a slide that comes from an incredible book. I got the slide from Dr. Joya Creer-Perry, and the chapter in the book from Marmot and colleagues is entitled Disparities in the Distribution of Disease, Illness, and Well-Being. And one of the things that drives me up a tree, it took me forever to figure this out. What bugged me about social determinants of health is that people talk about them like they come out of thin air, and they don't. They're actually born mostly out of policy decisions. But if you think about it, social determinants of health can both be positive or negative, depending on what you have access to. So it drives me sort of up a tree that people talk about them exclusively as like negative things, but they can also be positive things, right? If we appreciate what they're born from. So to talk about social determinants of health completely detextualized from the conditions that create them, I think is a real problem, which again opens us up to being able to have a different kind of conversation. I'm going to talk a little bit about structural racism as I move forward. And so I want to get everybody clear on the definition that I'm using, because that's the other thing about curating different kinds of conversations. You have to be clear in terms of, even if you're using the same words, what meanings you are using. This comes from a paper from a postdoctoral scholar of mine who's now a faculty member, Dr. Brittany Chambers. And we define structural racism as this, right? It's the laws, it's the processes, the policies, procedures that differentiates access to goods, services, and opportunities in society by racial groups, right? This is a really different conversation than, you know, oh, you called me an N-word, or oh my goodness, I can't believe we're in conflict because you don't believe Black women. Like, this is a completely different definition. And I put this here because, again, it opens up a different aperture that we can use to think about solutions. A lot of people have started to acknowledge that race is not a risk factor. Maternal health racism is, and I think the two can't be separated. This comes from a piece that Dr. Creer-Perry, who I already mentioned, wrote. She's a friend, collaborator, and colleague of mine. And I really think that we need to be more precise in our scientific language when we're talking about our research. And so for me, it feels very disingenuous as well as scientifically inaccurate to talk about race outside of the context of racism, because race only operates in racist systems in ways that I think impact health outcomes. So, you know, one of the other ways that you can curate a different kind of conversation. So I went back to Scientific American because I tweeted at the height of the pandemic that we needed to start having some conversations about differential access for differently exposed populations. And I know people don't like to talk about this because they always want to say, oh, we're about equity and we're about equality. But for me, I actually think that we need to start having conversations about how to distribute resources based on need, which means that the people who need the most should be centered in how we think about, talk about, develop our strategies and interventions, right? So I wrote this piece, you'll notice the date on March 26th. This was at the height of the pandemic after the Cuomo administration and other people in New York had decided to abandon pregnant people. And what I mean by that is they said that birthing people could not have accompaniment. Now, think about this. And don't get me wrong, like, I get the seriousness of the pandemic. I got it then, I get it now, right? But this whole notion that the propagation of our species would be limited and that we would shepherd new humans to this plane alone in an existing Black maternal health crisis made no sense to me, right? And so, but at the same time, we had colleagues and collaborators who were making the exact opposite argument. And so I think we as a scientific community, I think we as clinicians, we all have to get on the same page around how we're thinking about conversations that we have with the public, in partnership with the public, aligned with a public health principle of thinking about how do we distribute resources based on need. So, Dr. McLemore, what does all of this have to do with anything, right? Well, I hope these, examples have shown you that we're all not having the same conversation. So I'm gonna quickly introduce you to this thing I'm working on, and I'm trying to sort of really hone this for some essential writings that I've been doing, because then I will go back to those pictures And I will show you what a retrofit would have looked like. I will show you what a reform would have looked like. And I will show you what a reimagine would have looked like, right? So I'm a geeky person and I use Merriam-Webster. So the next 3 slides are going to have definitions from Merriam-Webster because I like dictionaries. For a retrofit, the definition that I want to draw your attention to is number 3. To adapt to a new purpose or a need or to modify something. Now, I really want you to understand that retrofit means that the structure as it currently exists is going to continue to exist. That is an important hallmark I will add to this actual definition, right? That the structure as it currently exists will continue to exist. Hold that point, okay? Reform has multiple definitions, just like retrofit does. I will direct your attention to the first one: to put or change into an improved form or condition. The other word I want to bring you to in this sentence is removal, right? A lot of times in health services provision, we always asking people to add stuff on, add stuff. We never talk about what can we take off our plate, right? So reform, think about reform is that structure may significantly change in ways that it might not be recognizable if it was just a retrofit. Like I live in California, right? We retrofit buildings all the time for earthquakes, right? Sometimes they look exactly the same. Sometimes they look really new. I always call those buildings, they have been reformed, right? So that's sort of the distinction between retrofit and reform. The actual basic foundational structure might change because you have the capacity, you've added in removal, taking something off the plate, not just adding on to it. I like to live in Team Reimagine. I'm sure a lot of y'all do too, where we want to imagine again, totally anew, like a whole new recreation, right? Here's the problem, and this is the crux of my talk. We need all 3, and everybody can't be participating in the same one, right? And let me tell you why. I always want to be on Team Reimagine because I think we can make a better world. I think this can all be different. Like I want to be on that team. Here's the problem though. The people in the now need our help, right? And some things should be retrofitted. Some things should be reformed, and some things should be reimagined. But if our entire scientific and clinical brain trust is all working on reimagine, we can't abandon the people in the now for the utopia we all want to live in the future, okay? It took me a long time to figure that out, that yeah, sometimes I'm gonna have to spend time, you know, in retrofit, because that's actually a really good skill set that I realize that I have. It's probably one of my superpowers, but I wanna be on Team Reimagine, right? Let me walk you through how we can do a both and how we can curate discussions so that we can make sure that people's skills are being optimized depending on where they fall in this continuum. And here's another thing to think about. This is not linear. This is a circle, right? Retrofit, reform, reimagine. It's a circle. It's not, even though I will use the word continuum, it's actually a circle. It's not linear. So why is this helpful? Well, if you think about it, you can use past, present, and future as a metaphor to think about retrofit, reform, and reimagine. And in terms of how you curate a discussion or a conversation, how you talk about your science, how you plan your next scientific study, right? I'll also show you how to do that in my later slides. We want to be able to do this because Black maternal health can be better. I think we all agree that we can do better, right? What people don't, they get really thin around is how do we do better? So I want to fix that how question, right? So let's go back to Katie Cosmon, right? A retrofit would be to reopen those rural obstetric units, right? A reform would be, let's train other staff to pick up those OB triage skills. Let's expand nurse family partnership and home visiting to assist us, since we know most of the postpartum deaths that occur happen in the postpartum period, right? Let's change birth settings. That's the reimagination, right? The drive up baby showers, the drive up prenatal care, mailing people blood pressure cuffs, being able to integrate telehealth, right? That's the reimagine, but we still don't want to abandon retrofit and reform because we need to be doing all of those things, right? Or when we think about like the crisis pregnancy centers or the pregnancy health centers or Title X and all this other, well, the first retrofits have already happened. With the new administration, we saw a repeal of the Mexico policy. We're trying to rebuild the Title X network. I told those people yesterday, the retrofit is to get the funding back to what it was during the Obama administration. The Reimagine is to start to seed partner grants with birthing organizations and with folks who are doing stuff across the reproductive spectrum. We could have a whole Davos and Switzerland or a DARPA, some kind of grand challenge where people who have mostly done Title X work can partner with people who've mostly done birthing work. We can figure some really innovative things to do together, right? So let's all start having the same conversation as opposed to trying to stay with how do we keep our own boat floating and let somebody else figure out that imaginary utopia we all want to get to. Or let's all keep our heads in the imaginary utopia and not do the essential retrofits that we need to do in our own environments, right? It's a both and. If we were going to engage around what happened with Serena Williams, the retrofit is let's believe patients and let's listen with others. And what that means is a lot of times when we have clinicians who are on rounds, there's a reason multiple people are there because we all hear different things, right? The retrofit on that is real easy. If you're less likely to believe Black women who are in labor and childbirth and seeking contraception care or abortion or infertility, maybe we need to have group appointments. Right? That's a retrofit though. A reform would be the healthcare team and the public health folks would simulate together. We would be in simulation so we all can work through, we can speed date and talk about how to keep our eye on the pregnant capable person and not be in conflict with each other, right? The Reimagine is let's diversify the healthcare workforce and let's add a community advisory and a community accountability board to your leadership team. That's a different discussion. Right? And I think sometimes we are all having these different discussions at the same time, and it's very confusing. So having a shared language is very helpful. This misinformation piece, right? Why can't we all just say we're going to put basic information about where our institutions are located, what kinds of services we are, like skeleton information on websites, knowing that people are mobile, knowing that they're using different kinds of social media apps. Why don't we use that to help update the public and be able to put some banners on those legacy websites? At the height of the pandemic, I was like, well, why don't we have 15 on Fridays with Fauci, right? Go on Instagram Live and answer the public's questions. That's a really different discussion than saying we're going to house information on static websites or push out content using our social media channels, but not really then merging those things together and connecting the dots for the public, right? Different ways. So let me tell you in the last couple of minutes, because I want to leave time for questions, discussions, insights, suggestions. I mean, these are just like some suggestions. They're not the entirety of all of them. And I think many of these ideas could be crowdsourced if we could all be having the same conversation. So let me tell you how we applied this in a research study that one of our learners did. Here in Alameda County, I'm in Oakland, California. We've been thinking about how do we screen for social determinants of health in the context of health services provision. And one of the things that we really wanted to be able to do is we didn't just want to look at social determinants of health. We wanted to look at social determinants of adversity and social determinants of resilience, because we were smart enough to appreciate the fact that social determinants of health are not like plucked out of thin air. They are born from policy decisions, and they are born from other types of resource allocation that we had some engagement around. The study has been ongoing for a bit, and we really wanted to use some exploratory and emancipatory qualitative research methods to really sort of get at how can we better screen and address and resolve social determinants if they needed to be resolved. How could we amplify and really, make sure that where things were working, they were spreading all throughout our organizations and institutions. So in California, we have a comprehensive perinatal services program, and the way that is operationalized is that there's a screening protocol that happens, and it allows us to link pregnant capable people to essential services, whether it's social services or health services, in a seamless way. And so our project, we really, really wanted to see where we could screen and act best to be able to reduce maternal morbidity and mortality in the most burdened communities here in Alameda County. How could we prioritize addressing social determinants of health? And how could we really marry the folks who were doing the work with the folks who needed to actually apply the work? So we use community health workers to really do the screening here in Alameda County. And so because they are the people closest to the pregnant capable folks that we serve, we wanted to center their thoughts, their innovations in terms of, well, how can we make this program better, right? A lot of people will go talk to the clinicians. Some people want to go talk to the patients. We actually wanted to center the people who were doing the screening in addition to the pregnant people they were serving, right? Again, centering the margins. The people who are most burdened generally will probably have the most innovative solutions to the problem. So that was sort of how we decided to reform the study. Right? We retrofitted it by adding in the community health workers in addition to talking to the pregnant capable people who were using the service, right? But we reformed it by centering their suggestions and their recommendations so that we could try out some new things. So we did multiple in-depth qualitative interviews with the community health workers. This is the demographics of who they were. And one thing I want to note specifically on this slide, you notice that the average time in their role was 4.2 years. A lot of times, public health and in clinical health services provision, we hire med students and nursing students and public health students who are on their way to their next graduate degree or on their way to school somewhere. The reason we got this level of longevity with our community health workers is because we hired pregnant capable people that we have previously served. So this right here makes the argument, if you have personnel issues or trying to maintain your support staff, view the people that we serve as your potential future workforce, and you will get longevity, and you will also be helping to develop themselves and their communities as part of that diversification effort of the healthcare workforce. The barriers, these shouldn't be surprising to folks, that the way the clinic was organized, the structure of the questionnaire in and of itself, and then there were patient level factors that really, really were barriers to screening for social determinants of health. And I want to put a pin in this last one, right? Because it wasn't necessarily so much anything about a deficit or a problem with patients. We learned a very important lesson in doing this qualitative work, and that is, some patients feel racially profiled when we ask about social determinants of health. And so if possible, one of the things that we found that was very helpful is when our clinicians would ask the question, you know, are there any of these things that you've identified that we call social determinants of health that you would like for us to address today? If there are any, please let us know. If you would prefer not to address these today, we will ask you again at your next visit. And the reason that language helped change the perspective is it allowed for the pregnant capable person to make a determination about whether or not they wanted to address that day, if they had time, if they had child care or they had needs where they needed to get back to. Like, it really opened up this whole different discussion. And we saw, you know, that people's comments towards the end of the study period were that they were feeling less racially profiled because they felt like they had more control over when and how the social determinants were going to be addressed. The other thing that we also learned was that what we may consider social determinants that are positive or negative, pregnant capable people have different opinions of that. So like, I'll give you another example. When we would talk about transportation, a lot of pregnant people wanted to know if we had taxi vouchers or if we had, you know, Lyft cards, or they wanted to know if we had transportation. They weren't necessarily so much interested in sharing what their mode of transportation was going to be, right? So again, not having the same discussions with the people that we serve. It was fascinating to find that clinical organization was also a facilitator for effective social determinants of health screening, and that the structure of the questionnaire, so it was a both and in the views of the people that we serve. But here's the one that I really want to point our attention to is team-based care. When we communicated to pregnant capable people what each person was doing with the information for screening, that really put people at ease around this issue of feeling like they were being racially profiled. The other piece was it really ameliorated the issue of people feeling like they weren't being heard because multiple people were asking them the same question, right? So what we ended up instituting was we did a huddle after we had the social determinants of screening with the community health workers, whereas the medical assistant and the clinician would all get together and we would do a quick huddle debrief so that we all had the same information. And we let the people we serve know that we were doing that. So it wasn't everybody asking the same questions over and over again and patients ending up feeling like, why isn't anybody listening to me? It was more explaining to them that we were all verifying and trying to provide additional opportunities if they wanted to address it. And if they didn't want to address any of it, then that was done, right? That was essential information we would not have gotten had we designed a more traditional research study that did not center the insights of the people who were actually doing the work. So these two opportunities actually came out of our work, and we actually took the recommendations that the community health workers had to the people at the state who developed the comprehensive perinatal services questionnaire so that they could consider that as feedback to be able to make edits and modifications to the actual screening questionnaire. The other thing, though, that we realized is that we needed greater clinician involvement because CPSP appointments were separate and distinct, but also generally aligned with a clinical appointment. And it allowed for billing of these visits that they wanted greater clinician involvement, even if it was only to come in beforehand and say, oh, hey, I see you're sitting with Anna, our community health worker, that's a pseudonym. And, you know, I'm going to talk to whatever you want to talk about when it's time for your clinical visit. Thanks for being here today, and I'll see you later. We found that interaction alone really not only improved the patient's experiences in our clinics, but it also helped the community health workers, right? Just a simple, hey, I know you guys are together. You know, when you're ready for your clinical appointment, the medical assistants will bring you back and I'll talk, you know, we'll review anything that you're interested in reviewing today. And if not, we'll think about it next time. That changed the entire process of how this was operationalized in a 10-clinic accountable care organization that serves primarily Medicaid population here in Alameda County. We're working on publishing those results, including how we use the framework to help us make decisions within the study. So, in closing, use of the retrofit, reform, reimagine, you can use other words, but we need to be curating conversations to get us all on the same page about what we're talking about, whether that's in research, in education, in policy, or in practice. If I can't tell you anything else, we have to distribute resources based on need. We have to get away from this mindset that everybody should get the same thing, because, you know, the burdens of disease and the burdens of death and dying is not equitably shared. So until we can get to a point where we can eradicate health inequities, we really have to have this discussion about distributing resources based on need. We need to get out of a divide and conquer mindset and get into a divide and success approach. And that's what retrofit, reform, and reimagine affords you the opportunity to do. You know, I have recently decided that it's very important that we highlight retrofitters, right? They're doing the hard work of keeping the ship afloat, right? And that should be rewarded in ways that where we see things are really working, that they will know that in that future that we're reimagining, that those retrofits will live on, right? So it's not a either or, it's a divide and success approach, not a divide and conquer. I think using this approach also really highlights for me the need for clear articulation and communication. If we are going to continue to try and rebuild our crumbling public health infrastructure, and somehow make sure that there's seamless interface with clinical health services provision and with our educational and training needs and with our policies, that we're going to have to be clearer in what we're talking about. And when we're talking about retrofits, I think it's totally fine to be able to say that we need to invest in public goods. And I think public health is a public good, right? I also think that public health can be reimagined, right? So we have to be very clear so that it doesn't set up these weird dichotomies where we waste a lot of time being pitted against each other, as opposed to really trying to amplify where we're at around that continuum. And then the final piece I will say is that I've learned this in my own research, even as a molecularly trained tumor markers of ovarian cancer person, all the way now to the work that I do in reproductive justice, is that community engagement at all levels becomes really clearer. So even as I think through our social determinants of health screening work here in Alameda County, we've tried to conduct some tweet chats and to think about, people who live in Oakland. We're going to do some infographics of this work. We'll probably bring on some community advisory board to my Instagram live, and we'll talk through pieces of the study. But we really have to take on the science communication piece in ways that I don't think historically we've had to, because I think that we, for far too long, allowed others to be trusted intermediaries or gatekeepers around the narratives of what the work is. And I think we really need, as scholars, as scientists, as researchers, we really need to take some of that on proactively with the people that we serve so that we can continue to try and build trust. So I am myself everywhere, and you can find me on LinkedIn and Instagram and Twitter, and that's my email address. And I am very much looking forward to any questions, comments, points of clarification, or discussion items that you have. And I'm really, really grateful to have an opportunity to talk with the participants of the symposium, and then I'll answer anything that I can answer, if that's helpful.
Awesome. Thank you very much, Dr. McLemore. Best part of my day, sit back and listen. Right? Just sit back and enjoy.
Well, I have to say, I mean, one of the things as I think about and as I work through this framework, as we have seen, so many conversations have been going on around these issues in scientific journals. And a lot of times those conversations are hidden behind firewalls. And I don't think that's helpful. And so as we continue to start to think about, especially during Nurses Week, after the start of Mother's Day, like sort of, this whole notion of, Women's Health Week, as we're trying to rebuild public health infrastructure, we have to get at this notion of how can we curate different types of conversations so that we can bring forward new kinds of solutions. And so for me, it's this bigger responsibility that I feel as a public scholar to curate those spaces where as many voices can participate. Like, we don't have to use traditional science communication in order to be able to build the kind of infrastructure that we want to see. We don't have to replicate, sort of the, peer-reviewed sage on the stage kind of ridiculousness. We can actually really think about what is the 2.0 version of public scholarship that's needed to come forward with new types of solutions. I tell people this all the time, and I see the chat, I'll look at it in a minute, but I came up during my PhD when we were mapping the human genome, right? I mean, I started doctoral study in 2002. And we figured out how to build multiple careers, hundreds of careers. We figured out data sharing and data use. We figured about multiple authors getting credit where people could still advance, as assistant to associate to full professors. We figured that out, and data sharing. So I don't understand why we haven't taken some of those innovations and brought it to nursing research, and brought it to public health research, and brought it to community engaged research. So for me, we've had some paths that need to be reformed, right? I wouldn't say retrofitted here, but they need to be reformed because community engaged data requires skill. It also requires community engagement at all levels, right? So you can't just take data that were collected in a community engaged way and then decide you want to extract from that, right? That's not how it works. But I do think there's some retrofits that we could do to really change the conversations and to improve the scientific accuracy and credibility that we have when we think about the kinds of work that we are all trying to do to advance health, not just for all citizens, but specifically I believe that if you center the most burdened individuals, that care actually really should improve for everybody, right? It's not a scarcity thing of, oh my God, they're getting something that we're not getting, but it really becomes this broader issue of, if we have innovations where people most burden, like I always say, if Black women were centered in all of our interventions, actually care should actually really improve for everybody, because there will be innovations that work for the people where systems currently don't work, which should trickle up, right? But I don't know that a lot of people believe that. So for me, it's this bigger discussion of how can we get more people to start thinking about how strategies can actually be deployed and designed that will help to amplify all the good work that folks are doing. So I see an interesting question. Does this really start at pregnancy, or does pregnancy just reveal disparities that may have started earlier in life? I think it's both, right? So I don't think anything just starts at pregnancy, right? I mean, if you want to have a chicken and egg conversation. But I think what ends up happening is pregnancy is one of those interesting conditions that allows us to step back and look at the ethics and values of a whole variety of other things. So let me start with this. Prior to COVID-19, childbirth was the #1 reason why people were admitted to hospitals and healthcare institutions in the United States, right? Let me say it again. Prior to COVID-19, childbirth was the #1 reason why people were admitted to hospitals and healthcare institutions in the United States. We have 4 million births, right? So that sentence alone should give you pause, right? Because that doesn't open a conversation about, well, should hospitals and healthcare institutions even be the place where birth occurs? Right? If you think like a lot of midwifery colleagues do, that it's a normal physiological process that has to be witnessed and attended to, you're having an entirely different conversation than pregnancy is a disease state to be managed. Those are two different conversations, and how we think about strategies to address those issues will be very different based on what frame you sit in, where you start from in that conversation, right? So I think it's a both and. I mean, I think pregnancy is a very interesting way to look at the lens as a health of our nation, right? I mean, we've always used maternal child indicators as ways to think about if our health systems are working or not, because technically pregnant people should be the healthiest folks in a hospital, right? So I think there's a disconnect again between how we're having the discussion and where we want to point our thoughts. So for our epigenetic friends and the people who are going to get on me, the DOHAD folks, the developmental origins and human health and disease folk, we can have that discussion around that intergenerational transmission of things. But I also know that interventions can help for resolutions of intergenerational. I just don't think that it's manifest destiny that I'm a Black person and I'm going to have some kind of harm in pregnancy, right? I mean, that it doesn't have to be like that. And so for me, it's this different discussion of whether or not the pregnant capable period affords us the will and the courage to think about how we support the health and dignity of like half the population. That's how I think about it. And so for me, I'm not looking to blame any one individual or any one pregnant capable person. To me, it's a bigger discussion of what systems are we prepared to put into place to ensure good birth outcomes, right? Nobody has gone into wealthy neighborhoods or done research on wealthy people to look at what's the minimum constellation of things that we need in order to ensure good health outcomes. Maybe that's what we need. So then we can make those public investments in order to make sure that everybody has access to those things. So to me, it's a different, I would turn that question around. I see a comment that I have to read because I think it will also spawn me to think about other different pieces as well. Of course, my mind is racing. And it says, I mentioned something briefly about having to go through Black women to access our scholarship. I wonder if you can talk about this, and does this help with the issue and disparities in publishing? I am working on using this framework, and is this choice a reimagining? So I am a huge prolific person. I think you've heard this. I write a lot in a lot of different mediums because the clear articulation of my ideas, in my opinion, is an essential part of my scholarship, right? And so the reason I wanted, if I knew I was going to get a free data visualization project, I want people to have to maybe stop when they go to Black Mamas Matter Alliance website and go through Black women and all the stuff that's on the website to see the kind of work that we're doing, right? And to think about centering the work of, you know, Black doulas and Black community members with lived experience and Black physicians and Black nurses and Black midwives and Black anesthesiologists, so that you can see how we distinctly conceptualize the work that may seed you having new and imaginative ideas about how you can engage towards health equity. Now, that said, I had my Cite Black Women shirt on yesterday because I get very frustrated when the same recycled ideas about how to do this work occur, because a lot of them are actually really grounded in stigma and shame and judgment and blame. And I don't think that's the path forward if you accept that structural racism is an essential contributor to the social determinants of health and why we see poor health outcomes in Black communities. Right? If you accept that, I don't understand how stigma and shame and judgment and blame are helpful in your citations and trying to design interventions. So for me, it's really trying to think about the sources of data that exist for us to think about the kinds of ideas that should inform our research. So that's how I think about it. And for me, citational practices is really important because I think that there's something inherently problematic if there are only men in your citations, because that means you don't know the women who are doing the work in that field. I think that there is something really wrong if you don't have any Black people in your citations, as if there's no Black people who've done that work. So to me, citational practices is yet another domain where we want to be intentional and thinking about when we're teaching learners how to conduct a review of the literature, that our epistemological stances or how we come to know things is included in how we make decisions in terms of whose ideas to cite. That's how I think about it. Let's see. How can new nurses or anyone at an individual level, if leadership doesn't share this view, work to integrate the R3 framework, especially retrofit and reform in health systems that are resistant to change? Or where's a good place to start? So there are three levers that I like to think about if we're talking the resources of money, right? So I think about resources is humans, money, and time, right? A lot of people, when you say resources, they think money. But let's start with the money piece, and then I'll work backwards with humans and time, right? So if your resource is actually really money, you're thinking about the levers of the federal government. You're thinking about the levers of, business and, companies, and then you're thinking about philanthropy, right? So if you're working at a healthcare institution and you're an individual, how will you push those levers of government and business and philanthropy? Well, a couple of ways to do that as an individual is make sure you belong to your professional organizations, because many professional organizations do advocacy day. Some of them do lobbying. Some of them do direct, the education of policymakers. So if your workplace isn't receptive to this framework, then maybe you should start with your professional organization. On the human resource time, right? Because money is not the only thing we actually care about. There's money and time, or humans and time. On the human resources side, you need to pair up with your peeps. You need to find who your folks are. Right? I mean, I learn this from the students all the time, that their capacity to organize and demand change, they are very helpful when I want to see change happen at my university. And we don't even have any undergrads. I'm at an exclusively health sciences campus. But when I want to get something done, I talk to the students. Right? So you want to be thinking about who are the humans that you need to connect with. And this is another reason why community engagement is so important, because having community advocates is powerful, especially if you have the right ones. right? Then you go to the time resources, right? If you know that an institution is entrenched and they are not prepared to either retrofit or reform or reimagine, do they deserve your time? I have divested from many organizations who have shown me that they are not courageous enough to even start to have these discussions. That's a waste of my time. So when you think about resources, think about it in the context of humans and money and time, because then that will make your choices easier, right? If your workplace is actually open to thinking about retrofits or reform, do you need some students to help you? Do you need a community group that might help push, right? Or do you even have the time, right? Is your institution so like it's going to go the way of the dinosaur? It's going to be like Blockbuster versus Netflix. If they don't see the handwriting on the wall, then maybe they aren't worthy of your time. So that's how I think about it. And I never do anything alone. I hate being an only. It's irritating. And so I always try to team up with individuals, with folks who either share my views or don't, but who appreciate the problem. And if we can get to the same page that we're all having the same conversation about the same problem, I can work with you. And I can use the 3R framework to be able to do that. So I'm going to move to the Q&A since the chat is now quiet. Let's see, this was outstanding. Can you please tell us more about reproductive justice framework and how it exemplifies R3? So reproductive justice, for people who don't know, was started by 12 Black women in Chicago. And I'm lucky enough to actually be working with a mother of RJ as a postdoctoral scholar that working with me, Dr. Tony Bond. And reproductive justice is a human rights grounded theory, practice, and political strategy that posits that all persons have the human right to birth, become a parent in whatever ways they see fit with dignity. They have a right, a human right, to not become a parent and to avoid pregnancy with the appropriate supports and dignity that they need in order to be able to do so. All human or all persons have the right to parent their children with dignity, without fear of violence or harm from any individual or from the state or the government. And that's regardless of if you're a carcerally involved person, someone who has child protective services, if you've lost children in the past, it covers everybody, right? It covers, parents of people who have had to deal with, the unarmed shootings of Black people. So, and then I like to add that reproductive justice also posits that we have a human right to disassociate sex from reproduction, which opens up conversations that we can have about consent, healthy sexuality, pleasure, sex education. So for me, the way that RJ fits, in the context of the R3 framework is this: reproductive justice is the path forward that we need in order to be able to center our work. But there are places where reproductive justice will ask or demand a retrofit. I'll give you a perfect example. Having infertility services covered universally, having abortion services covered universally, regardless of what your insurance type is. I mean, I still am quite embarrassed that your insurance type, whether it is employer sponsored or publicly funded, gets to determine what access to services that you have. That to me just feels really arcane and unfair, right? Because that says if you're poor, then again, going back to what are the minimum constellation of things that we need and able to ensure healthy outcomes, that you might not have access to what you need, right? That just doesn't sit with me well, right? If we have insurance, and I get the need for different kinds of plans, right? But this whole notion that exclusively who is paying for your coverage determines what access you have to services. I think we need to unpack that discussion. But a reimagine of, in the context of reproductive justice is something that I've been doing in my own work, which is I bring on community members to help me make budgetary and hiring decisions. I hire community members as co-researchers, especially if they run community-based or community-focused Black women-led organization, because they are experts by experience. And if I really believe that, especially in the context of pregnant, capable people, then they should be compensated as such. So for me, it's this different way of thinking about how we organize public health services provision, how we think about educating the future workforce, and what policies do we need to have in place in order to make that a thing. It informs different discussions in different environments, if that's helpful. And I can go into a ton more examples, but I do want to get to the second question. I see I'm running out of time. So how can we get away from spending so much time and focus on publishing peer-reviewed articles that communities won't have access to, when that is such a marker of success in the field, and moving towards communicating with communities that research is intended to benefit? Well, folks will notice much of my work is available and I publish. I make a purposive point of publishing in open source papers. I also make sure that if I do a commentary or an op-ed that's accompanying it, or an infographic, that I get laminated and poster versions for the community-based organizations that I work with. I also am starting to really think about, what does library access even mean? Like, could there be like a Reimagine would be, okay, let's get library access for all community-based organizations or Black women-led or Black women-focused organizations. I'm actually thinking about doing this, and we've been planning to try and pull this off for Black Women's Matter Alliance, such that when those organizations need access to PDFs or different published articles, that they will be able to come to BMMA as a repository to be able to receive those things, right? I think we as a faculty, and I'm using that as the faculty with the big F for those of us in academia, we need to have a conversation about promotion and tenure and what's necessary for people to be able to advance. I say this to audiences all the time. People are actually shocked when I say this, but I am the 5th Black tenured person. In the 118-year history of my school, I am the only currently Black tenured associate professor in my entire school, as well as on my entire campus. So we, as faculty with the big F and our academic senates, have the opportunity to think about what other metrics would we want to be able to use in terms of promotion and merit and tenure and other accolades. What are the other algorithms that we could use to take away or to remove some of that concentrated power in peer-reviewed work? It's one of the reasons why in my bio, you heard that I have, 71 peer-reviewed commentaries, op-eds, voiceover. There's a reason for that. And it's because the community members that I work with and work for are not interested in one currency that could be used that then is not translated for its use elsewhere. So I think we spend a lot of time on data generation and we don't spend enough time on data dissemination. And that, I think, will be a fundamental way we can build back public trust in the public good that is our research enterprise in the United States. I could go on a long rant about that. Whoever wrote me that question, if you want to be able to either tweet me that or email me, I can send you a whole host of how we can reimagine scientific peer review and publications, as well as how we communicate with the public. Because as a reminder, I tell people this all the time, taxpayers, for most part, fund people's work. And so they've already paid for the research, right? They shouldn't also have to pay for its dissemination. So as we think through the models of how we do our science, we really want to be thinking about that dissemination plan. And here is where I think philanthropy has done a way better job in terms of funding dissemination projects that I think is going to be really crucial moving forward as we continue to try and translate our scientific findings to the public. So I see it's 12:01. Is somebody going to tell me stop talking, or because I could keep talking?
Well, I'll tell you what. No, well, the good news is that we're going to have more opportunity, but thank you for peeking at the time. I think our plan was to take a quick 5-minute bio break, let people get up and stretch, whatever you need to do. And then we're going to come back and we are going to welcome, Dr. Charvonne. Holliday, Patricia Liggins, and
Yes.
Choo from the Department of Health, and round this conversation out with Michelle Ogunwole. So if you guys will just take a break and then come back. Thank you so much, Dr. McLemore.
Thank you, and I will be back. I'm going to the bathroom. I will be back.
Thanks, everybody.
Okay, I'll go ahead and kick us off. I'm just going to see if everybody is back from the panel. I think Dr. McLemore is coming back soon, so I'll give her another minute to join, and then we'll get started.
I'm on.
Oh, you're on. Awesome. Okay, so we'll get started, everyone. Thank you for your patience. And Dr. McLemore, I have to start off by saying, because I'm a reproductive health equity researcher and a huge fan, that was such an incredible keynote discussion. I think everyone would agree. And I'll just say one reflection for me. I'm certainly team, I want to stay on team Reimagine all the time. And so I think that what you've given us, at least for me, it's been really helpful for me to understand that there are other things that we need to do for the people in the now. And I will definitely take that away from this discussion. And I think for all of us, you gave us this beautiful model for us to really radically think about the worlds that we want to see.
Yeah.
And so really, really appreciate that. So really appreciate this process, and I'll definitely be using it going forward. So without further ado, it's my pleasure to welcome Dr. McLemore to our panel discussion. At this time, I'd like to introduce our other panelists. So the first person that I see is Dr. Charvonne Holliday. Dr. Holliday is an assistant professor in the Department of Population, Family, and Reproductive Health at the Johns Hopkins Bloomberg School of Public Health. Her research focuses on achieving health equity in women's health by understanding and addressing social and structural determinants of intimate partner violence and reproductive coercion. Dr. Holliday, thank you so much for being here today. The next person on my list here is Ms. Patricia Liggins. Ms. Liggins is a certified professional doula, and she's also completed perinatal community health worker training at Mamatoto Village here in DC. And she is the founder and CEO of Birth Supporters United, where she serves birthing people in all trimesters of pregnancy. She also serves on the Reproductive Health Equity Alliance of Maryland, where she's a critical part of discussions around setting a legislative action agenda for reproductive health and justice. So thank you for being here, Ms. Liggins. And then finally, we have Dr. Shelly Chu. Dr. Chu is a public health and general preventative medicine physician, and she's director of the Maternal and Child Health Bureau of the Maryland Department of Health. Prior to this role, she was chief medical officer at the Baltimore City Health Department, where she worked on various population and behavioral health initiatives. And she also previously served as a senior medical advisor for Be More for Healthy Babies, where she oversaw provider outreach and efforts for infant safe sleep. She's also an alumni of Johns Hopkins School of Medicine and School of Public Health, and we're thrilled to welcome her back. So thank you for being here, Dr. Chu. And just for the audience, we thought really carefully about the panelists that we have here today. And we really convened the panel because each of the speakers brings a different perspective to the issue of reproductive health and justice. And I think we have here represented on this panel a wide range of lenses, as like clinical research, policy perspectives, and of course, along with the lived experience of each panelist, I think it'll make for a really rich discussion. So I feel like the keynote that we just heard is a really great springboard for this discussion. And there's several themes that we talked about, both in the actual keynote and I think after in the Q&A that would love to explore with some of the members of the panel. So with that, I'll just get started. And I'll start first with Ms. Liggins. So, I think the theme of our symposium and the idea behind it was really to help scientists and researchers and other clinicians understand how social and structural realities impact health. So Ms. Liggins, I shared in your bio that you had kind of elected to expand your training as a doula by getting this perinatal community health worker this extra training. And I'd wonder if you can maybe explain some of that to the audience and what it means for your role as a doula and why you thought it was important for addressing some of the social and structural things that you see in your clients.
Sure. So what I think I took the most away from the training with Mama Toto Village was exactly that, the impacts of the social determinants on an individual's health, much less a pregnancy. So we spent a lot of time in the birthing world educating birthing people on how detrimental stress can be on their pregnancy, on the health of their baby, and even outside of pregnancy on health generally. I mean, it ages us so much faster than if we were not stressed or if we were in a more stable environment. We didn't have all these major and minor stressors that were piling up on us every single day. And when we think about our ability to just get through the day, much less like keep the regular functions of our health going, and then having them functioning in a way that can develop a growing living creature inside of our bodies, we really understand that, like, psychologically, this is kind of a setback. It's a stumbling block or an obstacle for us to be able to manage our health. If you're thinking about like financial struggles or something like that, think about like the ability to be able to just eat healthy food items or be able to have access to those things. If you can't eat healthy foods, then you're already lacking in the appropriate nutrition that you need to keep yourself healthy. That's going to be also impacting the development of your baby. Thinking about like your education status means that that's going to potentially impact your job or where you can work and how much rest and ability to just take healthy breaks or even to be able to get off from work. So it's like our socioeconomic status or our environments or the things that are impacting us on a regular basis, they operate in sort of a cycle. Each one is impacting the other, and that is inclusive of the babies that are inside of our bodies. And so that's kind of what I got out of that training. I didn't actually go into Mama Toto Village understanding what I was going to get out of this. But by the time I came out of it, it just kind of was very eye-opening for me in recognizing that there's so much more to childbirth than I ever would have imagined.
Thank you for sharing that. And certainly I think that there is this increasing awareness about the role of doulas like yourself, and especially people who are trained and have training around structural and social inequities and the ways to address that in their clients, as well as something that Dr. McLemore touched on earlier in her presentation, which is just the issue of mistreatment as well. And I know that is also kind of a part of your work in supporting birthing people throughout their process. And so I guess the other kind of question I actually wanted to pose around that and is to Dr. McLemore, because I know that you're a strong proponent of Black doulas and Black midwives and other birth workers. And certainly they play a really critical role. And we've also seen in mainstream media that there's been this kind of new attention to how Black doulas may be an answer to the Black maternal health crisis. And I wondered if you could kind of walk us through some of the potential risk, I think, of putting that all on our people like Ms. Liggins to kind of to save Black mothers.
Yeah, so can you guys hear me?
Yes.
Okay. Yeah, first of all, I'm just so grateful for Ms. Liggins, because I know Aja Nahiri, and I love the Mama Toto Village folks, and they do important and incredible work. I work with the Roots of Labor Birth Collective here in Oakland, and like Mama Toto's Village, members of Black Moms Matter Alliance. And one thing that we've been trying to get people to understand, at least in the retrofit, reform, and reimagine kind of situation, is doulas should not exclusively be responsible for a problem they did not create. So for me, I think that there is a fundamental flaw in viewing doulas as the penultimate response to the Black maternal health crisis, because then that means nobody else is doing any work to get their people. And so for me as a nurse, for us as, for our physician colleagues, for our anesthesiology colleagues, for our front desk staff, right? This has to be a joint effort. There is no one segment. And I think all birthing people should have doulas, by the way. I think they are some of the most magical human beings on the planet. And I say this for two reasons. And my good colleague and collaborator, Dr. Karen Scott, talks about this more eloquently than I do. She says and taught me that doulas move with people through time. We as clinicians manage time during labor and birth. Those are two different skill sets, right? And we need both. So this notion that we function from scarcity, that somehow doulas are encroaching upon our territory, or we are the birth keeper, I think all of that is not helpful. What we need are to understand that doulas know how to move with humans through time, which is not necessarily a skill I think that physicians and nurses and midwives, we all don't learn. We manage time. And so for me, I think the ways that doulas do help, they're an additional set of eyes and ears. So again, going back to that group appreciation for hearing things and listening to things. Number two, doulas are people who are uninvested in any outcome except for a healthy birthing person and a healthy baby. Like, they're not invested in anything else. Right? They want to make sure that the constellation of people around the birthing person are fed, are rested, that they have the information that they need to make the decisions that they need to. But otherwise, right, doula's attention are fully on birthing people, right? Those of us who are health services providers, we have other things that we have to pay attention to. Pain management and, making sure that, we don't have poor oxygenation or deceleration. Like, we have other things, right? So can't we all just say we have common goals, but different roles? I also think that doulas do a third thing, which is they remind us in their essential roles of both the art, the skill, and the science of being with birthing people. They bring celebration to births. They bring joy, they bring music. It is such a different model. I have seen doulas do things that I wish I could do as a nurse for families, right? And so for me, they hold that space in my mind for the reimagine of caring that I think we all want. And we're struggling with how to balance in our other distinct roles that we have during childbirth and the labor process. I'd keep going.
I really appreciate that. I think some of these conversations you just never know the things that are going to stick with you that people say. And I never really heard it presented that way. And I guess my reflection back to is that, I think a lot of us think of doulas as magical, but they aren't magic. Like, they're not going to change the systems and structures. And at least for me, I appreciate some of the clarity in that, the distinction of their, the important roles that they play, but some of the limitations.
Can I add on to that just a little bit?
Of course.
And so then, first of all, thank you, Dr. McLemore, because that was beautiful to hear. And I'm so thankful. I'm sorry, hold on for 1 second. I'm sorry, I got home and the maintenance man was here. So taking what Dr. McLemore said and bringing it back to the social determinants factor, you think about that magic goal that she so generously labeled us as. Think about how that impacts or combats those social determinants. So then we provide somewhat of a strategy to go up against those things that are weighing down on that birthing person. And so when you think about, like, I got a million and one thing as the birthing person, I got to get to the doctor's appointment. I got to make sure my bills are paid. I got to make sure I make it to class or work. I got to make sure that, you know, there's food in the fridge. If I have other children to deal with, all of these things that are weighing down and adding to the stress, then the doula comes in and they're able to make sure that you have someone there with you to keep up with what's going on at that doctor's appointment. If there's a doctor's appointment that is missed or they don't understand something that happened, then they can text. I mean, it's a simple text message instead of calling the office, being on. I mean, it's just the little minor stressors that doulas kind of swoop in and save the day, for lack of a better way to say that. And that builds up a confidence that is combating that stress that is, hindering the development or the health of that baby and of that birthing person. And so that's another way that doulas kind of come in and have this like positive countermeasure to the social determinants that people face on an everyday basis.
Thanks so much for adding that. I think that I want to get you in here, Dr. Holliday, as well. And I was thinking about some of these things that we were talking about, social determinants of health, and certainly in Dr. McLemore's keynote, she discussed a little bit about the thing that comes before that, which is the structural racism. And I know we've been talking a lot about birthing people right now, but I also know that your work in reproductive health and justice also focuses a lot about on relationships and families and community influence as well. And I wondered if you could talk a little bit from your vantage point in your work, discuss how structural racism and some of these inequities show up for the population that you're looking to serve.
Absolutely. Thank you so much. And it's an honor to be on this panel with each of you. And thank you so much, Dr. Ogunwole, for being an excellent moderator. So I really want to uplift what Dr. McLemore said about common goals, different roles, and also what Ms. Liggins said about, the Black woman as being the savior, right? The savior complex. We're having to be saviors as doulas or saviors when it comes to an election. And then we also see common themes like this when it comes to violence as well. So some of the work that I've been able to do here in Baltimore City is around police reporting, working on a project led by Dr. Michelle Decker with funding from the National Institute of Justice. And one of our key findings is that Black women do report more, but there are specific considerations around race, gender, and class that are trade-offs for safety. So in continuing on with the theme of this Black woman as the savior, Black women are having to consider calling the police for, and also considering the fact that when police show up, that they may kill their partner. Maybe it's the father of their child, it's their loved one, right? So they're reluctant to call police because of structural factors related to disproportionate killing of Black men at the hands of law enforcement. Other factors that I can talk about related to violence is just, first I want to clarify that Black and brown people aren't the only folks who are experiencing violence, right, in their intimate relationships. But we do know that there are structural and social factors that exacerbate these experiences. So in another project that I'm co-investigator on, we're looking at the influence of housing and the impact of structural racism like residential segregation and, sorry, I'm blanking on the other, neighborhood deprivation, sorry. And so in our finding, we're evaluating housing interventions here in Baltimore City, and we found that women who experienced abuse were rehoused in census tracts that were significantly more deprived and significantly more racially segregated. And so they're having to trade off safety for housing stability, right? So men are more likely to experience homelessness and housing instability, but women are more likely to experience housing instability and homelessness as a result of their intimate partner violence. And so what we're finding is that homelessness and housing instability among survivors is exacerbated by some of these structural factors where women are ending up in neighborhoods that are low resourced, and they either they're dependent on their partner or ending up in deprived neighborhoods. Other issues that I want to just lift up. So I work with both men and women in my research on intimate partner violence. And the reason for that is that I work mostly with women as survivors, and I also work with men as people who cause harm in their intimate relationships. But part of my work with men is to understand how to address some of these structural factors. So I'm fortunate to partner with a community partner here in Baltimore, House of Ruth, Maryland. And through my research and also partnering with them on additional multidisciplinary research, we're able to reform, to use one of Dr. McLemore's words, reform their abuse intervention program such that it addresses some of the social and structural factors like lack of unemployment in Baltimore City, some of these mental health issues that are exacerbated or facilitated by structural racism, violence in our communities, co-parenting issues. So we focus on those things. So the men who are engaged in the abuse intervention program at House of Ruth, these are men who have been arrested for using domestic violence. And so part of the process is it's cyclic. So these are predominantly low-income Black men. They're not the only men who are using harm, but these are the men who are court-ordered to this abuse intervention program. And we've heard from them that at times they have to consider paying the fee to attend the abuse intervention program or feed their children. There are also challenges with transportation. And so long story short is that some of these barriers are resulting in increased criminalization, right? So if they're not able to attend the abuse intervention program, they go back to jail. But if we can create co-located services to address some of their needs, so having probation and parole on site, having mental health services on site, parenting services on site, those types of things, it's our hope that we can reduce recidivism related to violence.
Thank you so much for sharing that, Dr. Holliday. And as you were talking, you kind of covered the spectrum of some of the work that you're doing. It really reminded me something that I think Dr. Kamara-Jones says all of the time, that that racism hurts us all, and I think this is a perfect example of that. Even in the ways that we're trying to reach for solutions, it's challenged in that space. And so I certainly appreciate the work that you've been doing, and I wanted to actually kind of turn to Dr. Chu now, because, I think we've been talking a lot about these social determinants of health, and certainly, at the individual level, we talked about these structural influences. And I think you're charged with kind of a broader mission to promote the health of both of birthing people and their children. And I was wondering, from your role as a director, how you think about doing this kind of across populations and not just at this individual level that we've been talking about.
I just wanted to say thank you for having me here, and it's really an honor, and thank you so much for wonderful moderation as well, and the keynote, Dr. McLemore, was incredible, so just thank you so much as well. I am Shelly Chu. I'm the director for the Bureau of Maternal and Child Health, and so I think, within the State Health Department, which is a large state agency, there's over 6,000 employees. I think we are we're a part of this, but I think really what's important is that we can't do this work alone. And so we need the partnerships, we need to be centering communities, and we need to be working with community-based organizations as well. And so I think really just to, I think, uplift what has mentioned before as well, which is the same, working towards the same goals, but having different roles. I think that really resonated with me, because I think the task in itself of how do we eliminate disparities, how do we work towards addressing the structural racism, the systemic racism that influences the social determinants of health. I think then, I think we each have a role to play in those pieces. In terms of the Bureau itself, we do have specific programs that we do oversee. So we administer, and we work with the local health department. So in Maryland, there's 24 local health departments that we work with. And so several of them have the home visiting program. So I think working to, what Dr. Holliday mentioned about how do we co-locate services, how do we bring care to where people are, I think that's really also a tenet of public health as well. It's just trying to remove barriers. So I want to mention home visiting and really wanting to expand home visiting. I think with that comes, a lot of other logistical things to mention, sort of, what about funding? What about, the ability to hire? What about training as well? But I think the want is there. In addition, with the local health departments, there is sort of these care coordinators, community health workers who are on site to help with navigating these complex systems of care as well. And so looking towards to sort of expanding, their capacity, which, they're also with the local health departments, they're also in charge of COVID right now, all the testing, all the vaccinations, and then also the contact tracing as well. But I think, in terms of the strategies, I think they do need to be broad, but they also need to be intentional so that, as Dr. McLemore had mentioned, to ensure that those who are in need are getting the most resources as well. And that really resonated with me. So I just also wanted to thank Dr. McLemore, just really emphasizing that as well, because I think that's sort of, we have to be intentional in terms of our interventions and the work that we're doing as well.
Absolutely. Thank you for sharing some of the work that is going on, I think, within the state that I'm sure a lot of people in our audience are interested in knowing. One of the things I kind of just wanted to circle back in, and then I'll answer, I think there's a few questions in the chat, but I know Dr. Holliday, you kind of mentioned that in your work, you also include men, and I was reflecting on Dr. McLemore's presentation and this idea that we've been talking about reproductive justice, that we have this choice to have children, not have children. And certainly, as she mentioned, that a lot of people with the capacity for pregnancy will spend a lot of time trying to avoid pregnancy. And I know this, these issues of consent and kind of, reproductive choice, et cetera, are themes in your work. But I was also wondering, Dr. McLemore, because we didn't really talk too much about the role of men in this kind of frame, in our conversation here. And so I was just curious how you think about it in your work. And I would invite Ms. Liggins too, I think, if you have any reflections on that.
My language was purposefully gender neutral because I work with Black, Indigenous people of color and queer folk. And so this notion that men would be excluded from anything I said is, number one, inaccurate. And number two, I think we need to really sort of disrupt this notion of toxic masculinity and gender oppression. That said, I've done a couple of projects with students specific to the needs of dads in the context of preterm birth and thinking about their needs in neonatal intensive care units. When I think about when my parents needed, when I was born a preemie all them years ago, and sort of really like that's why I use the language of constellation of people around the birthing person. I know it's a mouthful, but like I'm the aunt of the year, right? I mean, I have kids all over the country who I've never birthed, right? That's not my thing. I don't live with children, but I have kids all over the country. And one of the cool things about reproductive justice is your role as I guess the analogy is as a village, right? You want to be a villager. I actually want to be more than that, because that assumes only that humans can be part of that, right? And we know that our existence on this planet is enhanced by our dogs and our cats and, all our pets and everybody, right? So this whole notion that the constellation of folk around a birthing person matters is really important. That said, Dr. Holliday said something that's really important, and I don't want it to get lost, around co-located services and how racism and violence disrupts communities. Because for me, the one thing I will also say is the criminalization of pregnant people just doesn't impact the pregnant person, right? So I mentioned my good friend, Dr. Carolyn Suffren, before she left the Bay Area, one of the things that we were working on is really providing doula support for carcerally involved individuals. And, you know, to know that mass incarceration has had such an impact on Black families, on Black communities, that, you know, we really sort of need to upend our whole idea about how we think about criminality. When we know that 88% of people who are incarcerated are already parents at the time of their incarceration, then we don't even talk about the impact of carceral status on their parents, right? I mean, so I think we need to have we need to have a whole different conversation about the constellation of people who surround, support, and lift up pregnant people, because there's a role for everybody to play. And I'm curious about the structures in terms of how we can create environment where everybody can play those important roles.
And then from speaking from the role of a doula, one of the things that my experience has taught me is that, like, there is a responsiveness from the role of a dad, those who identify as father figures. There is a responsiveness to that feeling that there is purpose for their being there. So what I have been taught, and in my belief system, we talk about how men, they have a sense of purpose that they operate in, and when they feel like their purpose isn't needed, they respond to that in a way that we aren't expecting. And so when you get into thinking about the role of dads or father figures, or even just partners in the lives of not even just the birthing person, but that child, the extended family, and so on and so forth, it could be, or my experience is that it is a response to not knowing what to do, not being included. And so just like that birthing person is not included in their own birthing experience, well, we need to extend this out to the partner as well. And so when they get to these doctor's appointments and they're just sitting in the corner looking around and twiddling their thumbs, they're like, do I really need to be here? Yes, you do. So then that again goes back to what the role of a doula is. If you are really truly being a doula to that family, you're not just working with that birthing person, but with every, what Dr. McLemore called it, the constellation of the birthing person. So the people that are connected to this person, the partner, the in-laws, the grandma and grandfather, the siblings. We do so much more than just work with the birthing person. My job is to teach the partner how to use a rebozo, how to be involved in comfort measures and these different positions. If I haven't taught you how to do that, then all I did was take your place. And so just shedding some light or uplifting the fact that partners are also involved in both, on all aspects of the birthing person and that child. So that was what my experience has kind of shed light on for me.
And this is Shelly, and I just want to add that as you asked that question, I was thinking, oh, the Bureau, that's just the name, Bureau Maternal and Child Health, and that just in that some other health departments too, it is I think the name is often broader. They'll say Family and Community Health Services. And then the second thing I just want to mention is that Maryland as a state has embarked on something called this statewide integrated health improvement strategy. So it is tied with healthcare finances and the total costs of care, of how hospitals are being paid. But in addition to that, it's all really focused on these 3 population health domains. And so one of them is on maternal health, specifically decreasing disparities, severe maternal morbidity. But all that to be said, these are specific goals, but in terms of just how do we get there in terms of the strategy, just echoing what Ms. Liggins had mentioned and what Dr. McLemore and Dr. Holliday had mentioned as well, is just that it really needs to be sort of that constellation, and it's not just one individual, but it's really everyone as well.
Thank you for raising that. If I can just jump in really quick.
Yes.
Sorry. I just want to, I have a comment and a question. The first comment is that I think it was Ms. Liggins mentioned men's purpose. And so from the work that I do with men around reproductive coercion, one of the things that we know is that sometimes men will coerce pregnancy because of a lack of purpose related to structural factors. So for example, they fear being incarcerated, and so they want to leave a legacy, or they're involved in some type of activity that they feel that they won't be around, whether it be community-based violence or incarceration. And so I was curious if, because I don't know if issues like this are addressed with doulas. And also, I guess I'm thinking about intimate partner homicide risk that's increased during the pregnancy period, postpartum and prenatal periods.
It depends on how you think about the data. So, we also know that there are, sort of issues when people are trying to end pregnancies, and we know that there are also issues where people are trying to become pregnant. So it depends on which data you look at. So, my mentor, Dr. Sarah Roberts, who's at Advancing New Standards in Reproductive Health, has done some work with Amani Nurujeta from UC Berkeley, who was her dissertation chair, to really look at what happens with pregnant people and violence, regardless of how the pregnancy ends. And they looked at that within the Turnaway study data for people who continued an unwanted pregnancy for term and people who ended pregnancies. And so the data is kind of mixed. Similar on the infertility side. So, we know that for some people, pregnancy becomes that sort of lightning rod that exacerbates interpersonal relationship issues. And so I think it's mixed to sort of try and tease pieces of that out. But you're spot on in terms of this piece around purpose, because I also can't believe I didn't say this during my talk, and I'll have to pinch myself, but we will never resolve the social determinants of health or the inequities in health if we don't restore the social safety net. Right. And so this notion, Dr. Shelly, that you were talking about in terms of really trying to understand, we can't, if we don't have the adequate supports that people need to be successful, then we're never going to resolve this in the health sector. Right. And so the question you're asking, Dr. Holliday, I don't know if you know it or not, is super prescient because the work that you're trying to do lives at the intersection of public health, health services provision, social services. I don't think we can do one without the other. That's why I think the data are so messy.
I agree.
I agree too. I don't know if the other part of that question, what I heard was you were asking about the role of the doula. Is that what I heard at some point in there? Or
I wanted to let Ms. Liggins answer that.
Yes, I did too.
I don't speak for doulas.
Yeah, no. I just wanted to lift it up because I just wanted to make sure that if Ms. Liggins heard it, if she had anything to say.
I kind of blanked out, so I was going to ask if you could just repeat that end of the question.
Sure. I was hinging on, I think it was your point about men's purpose, and men are definitely invested in their child's well-being, and sometimes it's a motivation for them to stop causing harm in their intimate relationships. And I was wondering if doulas are able, if they address intimate partner violence and also kind of focus on the prenatal and postpartum periods as being increased periods of risk for intimate partner homicide.
So I think that depends on the doula that you work together with. I from the community that I've been a part of here in the DC, Maryland, and Virginia area, we work, or from, the people that I know, they work really hard to make sure that dads and father figures know you are welcome here. Please attend. We want to work with you. But expanding that out to the areas that you and your career touch on, that takes a really, really in-depth training and education that not all doulas are given. And so right now, I know I saw in the Q&A that someone asked about getting, how do we get doulas paid? And and when we go back to thinking about it, it really goes into what is required in becoming a doula. What does that training and certification look like? It's like doulas, you guys might not know, but there's doulas that do everything. They have sex doulas, they have conception doulas, they have doulas who deal with bereavement. And so thinking, and there are even doulas that teach fathers. There are doulas for fathers who are out here, like they are fathers themselves who want to work with others who are stepping into that role and identity as a father. And so like, there absolutely needs to be an expansion where we are trained, you know, for those of us who aren't. So Mama Toto Village, they did include that. How do you work with people who are victims of domestic violence? How do you work with people who suffer from substance abuse? They do this kind of like case management and caseworker education piece. It's not expanded out. You're not getting a degree, but at least you're aware of what is really going on in the community in case you stumble upon it. And if you do stumble upon it, you're not lost. You're not coming in here and you don't know what to do. And the, you know, the family or the birthing person is staring at you like, please help me. I don't know what to do. And you're like, oh God, I'm not versed here. This is not my area. We need to be able to support you through all of life's ups and downs. We need to be able to be trained to be able to support you, because that's what we're here for. And if you aren't able to support me because of my circumstances, then you really don't have a purpose here, in so many words. And so kind of bringing that full circle, there needs to be more education on how to respond and be supportive in those places, especially as doulas, where we are going into the homes and we are working more intimately with these families, and kind of like bringing this like prenatal visit or provider visit gap, like from 1 month to the next. We're kind of shortening that gap. We need to be able to work with each and every different circumstance that we might come to face.
Well, thank you so much for the explanation. You're right. I actually didn't know about some of the things that you raised, Ms. Liggins. So I actually didn't know that there were father figures who were participating as doulas. And I think that that's actually very fascinating. And I appreciate you lifting up just the fact that you all are not a monolith, that you do a lot of things. But when you were talking, I was just thinking about, I know that not all doulas get this kind of training, right, to do this work. And I did want to address this question in the, in the chat about, like, there's somebody said that it's so difficult to get, I think the question is, how do we get doulas paid? We know that they're important, but most insurance doesn't cover, and neither does Medicaid. And I think that's an important point, most especially when you're talking about that you went through all this training and you've done all of this work, and now you're going to people's houses all the time, which I know you do, and there's still not ways to pay for it. And so I'm gonna, I might throw this to Dr. McLemore to see if she has some thoughts, and Dr. Choo, I also welcome any reflections.
Well, I want to thank Dr. Campbell for asking that question. I know Jackie Campbell, and she's done some incredible work with Futures Without Violence. And so I really appreciate the question. I'm glad to see you here, even though I don't see you. Couple of things. So number one, our team and a lot of other teams believe that doulas should be paid a living wage. Number one, just flat out. Number two, our team pulled together a healthcare spending account and flexible spending account protocol that 2 student summer interns wrote. We keep that freely available on our website. So if you're serving people who are employed and they have healthcare spending accounts or access to flexible spending accounts, we have a whole path of how you can do that. So that's the sort of party line, I'll say. First of all, reimbursement from insurance, I think, is a model, and we have some PCORI funded work, Patient-Centered Outcome Research Institute work that's being led by Dr. Cassie Marshall, who is a professor at UC Berkeley and a colleague and collaborator of mine. I caution people around reimbursement models because doulas is a trade economy, right? So we have physicians who actually don't even take Medicaid because reimbursement rates are so low. So that's one solution of many. What we found here in California that actually works better is if we get block money to public health departments. So this the retrofit is give money to the public health departments, and they can fund either doula collectives or collaboratives. They can fund community health workers in partnership. That's the retrofit. But the Reimagine is direct payments to doulas that will allow them to do their essential work without putting all the red tape in that the rest of us in healthcare hate. So, you know, not to put a plug out there, but I'm going to do it anyway. SB 65 here in California, introduced by Nancy Skinner, is our version of the momnibus. But the federal momnibus that Rep. Oma Adams from North Carolina and Rep. Lauren Underwood from Chicago have put forward a payment structure to be able to not only educate and train doulas, but also to make sure that they're appropriately compensated. That said, I work with one of the master doulas in the universe, Linda Jones, who's done this work for almost 40 years, and she is well respected and just has amazing outcomes. You say her name, everybody knows her. She will, if she would pinch me right now and say, I've never been certified on it. Right? So this whole one size fits all that we've been accustomed to in nursing and healthcare and public health, in my opinion, is not a good model to think about how we want to partner and engage with doulas. We are going to have to reimagine making space for all the incredible work that they are doing, because we don't just see them as an ancillary to fix stuff. They are doing something in a lot of places and historically have been doing things that we've always wanted to be able to do, but have been limited by our institutions from doing. So this conversation needs to be wrapped up. Why can't we get them paid, or they're not reimbursed by insurance? Actually, the converse question should be, what changes do we need in healthcare financing for more people to be willing to take care of birthing folks? Because doulas, in my opinion, are obviously doing something right. And there are lessons that we can learn from their model. So I'm gonna pass it to whoever else will take it up from there.
So I'm just like busy scribbling down notes because there's a lot of good stuff here that need to go back and look into. And I think that one of the things that when you were speaking, Dr. McLemore, I was just thinking that there's certainly a tension in what I think about clinical medicine, about this fear about that we would be sacrificing safety, quality, in the name of being like thinking more creatively or broadly, like you're saying, about what it means, what it means to have expertise and allowing that to stand as it is. And I don't know the answer to that, but I just was reflecting that there is a tension that I certainly feel as a clinician and as someone who work, Ms. Liggins and I work together on some of these issues, trying to get around that. So I was just raising that kind of tension. I think there's a question in the chat for you, Dr. Chu, about home visiting. Sorry, I'm having a problem like seeing
yes, I see
question fully the way my chat's set up. Wondering if you can talk about the role of your office in early home visiting innovations around infant health, around maternal health, i.e. not just infant health.
Yeah.
Equity. This is another, I think, social, to bring it back to our topic, I think that's another way that we think about addressing some of these social and structural determinants of health through early home visiting.
Oh yeah, and thank you, Wendy, for that question as well. I do think our early home visiting office, they do have a large role to play as well, but then also noting that I think within Maryland, they're not the only ones who are implementing home visiting throughout the states. There are other state agencies as well. And then the second thing is, I think, just really understanding where within Maryland we need to prioritize our resources and making sure those who need it the most have access to the resources as well. And then the third thing I just want to mention is that when we talk about home visiting, it does get, there are many models as well. So there's the nurse-family partnership that Dr. McLemore had mentioned in her presentation, and there's others as well, Healthy Families America. There's also such great promising practice models that maybe some of the local health departments are implementing, or several of our community-based organizations are implementing as well. And so right now, with the structure of how within our Bureau, it's the McB, so the Maternal, Infant, Early Childhood Home Visiting which gets funded through HRSA, they very much promote the evidence-based programs as well. And so there's about 20 different, at least about 20 or at least a dozen different models. And then there's also these promising practices as well that actually we know just from data on the ground that have been, they also have great outcomes as well, but they may not get funded through this federal program. So how do we open up and share and have them also still provide care as well? So, I think that question also reminds me of Dr. McLemore's sort of just reimagining sort of, the converse of the questions of, how do we look at, certain systems and how do we redesign them and reimagine them for the future so that these programs are implemented so that they address the needs for everyone.
Thank you for that reflection. And I think that we are kind of running out of time here. And so I will thank all of you all for participating in this panel. And certainly, I think that we've just covered such a range of things. I mean, certainly the constellation of the people around the birthing person, and also, at least for me, and I think for everybody, raising this issue of the importance of language and kind of words mattering in this, that's certainly something I will also take. And Dr. Holliday even raising this issue of purpose, right? And how we reflect on that in our work. And then, I think this bigger thing, which Dr. McLemore mentioned, and Dr. Chu, you also mentioned about like asking different questions. And I mean, I guess it seems simple, but I think that's another thing that I'll take away as I, try to think about this, this framework that was proposed in the keynote, is that sometimes I think that we ask the same questions. And so maybe just taking a step back and saying, what's a different question I can ask? That will help me think about this problem in a different way. And so there's just so much rich information here from everybody on the panel. And thank you so much for your participation. And thank you to the audience that's been here for also participating in the chat. And we are wrapping up today. And so I'm actually sending a thank you on behalf of everybody on the committee and on behalf of the center as well. So thank you all.
Thank you. Bye, everyone.
Hey, thank you, everybody. Thank you.
Thank you. Such an
Thank you,
unbelievably perfect day. Oh, so
Thanks, you guys.
motivated.
Woohoo!
Thank you.
All right, cheers if you